Ladies and gentlemen, those of you who are here, I know everybody's trickling in little by little. Real quickly, I want to introduce myself. My name is JT. I work on behalf of Omics with JSP Entertainment, and we want to welcome you here. I will be doing the audio and video recording, loading up your presentations, those that are different presentations. We do want to let you know we are live streaming this on the web on YouTube, and we are recording it. Now, if you have sensitive material or material that has not been published and you do not wish that to be, please let me know and we will turn off the recorders so we will not record you if you're not want to be recorded, okay? Now, a couple of rules real quickly. Everybody pretty much has 20 minutes. Now, some special speakers might have a little bit more time, and that's fine. Whoever has that little time will, of course. The thing is, if you have 20 minutes for your presentation, that's 20 minutes for your entire presentation and question taking. It doesn't mean take the whole 20 minutes and then I'm going to take another 5-10 minutes for questions. Okay. Now, if we have doctors who do not show up, then we'll have some extra time that we can spread out between the colleagues and your doctors and all that. All right. So, anyways, is when you have 5 minutes left in your presentation, you've been giving your presentation, I'm going to be in the back going like this, 5 minutes, flashing a little light at you. That lets you know you got 5 total minutes left. Please do not step over into your next colleague's time, because everybody has just that a lot of time, and we don't want to put people behind. So, like I said, when you ask, you have 5 minutes total left. Okay. Again, in case somebody doesn't show up, then we'll be able to throw the extra 5 minutes, and then to this doctor and this presenter and this presenter. All right. Just want to let you know. Thank you very much, and I welcome you here to Chicago, Illinois, United States of America. We're going to have a great time, and I hope we have wonderful presentations. Okay. I'll be right back, and we'll be getting ready to start right now. Thank you, folks.
A very good morning to all of you. This is Dr. Narinder Kaur Multani, a professor in the Department of Physiotherapy, Punjabi University, Patiala from India. It's my proud privilege to extend welcome to all the speakers, sponsors, delegates, and the who are participating in 3 days event that has been entitled as an international conference and exhibition on pain medicine. This is being organized by the Omics International Conferences, which was established in the year 2008 with an aim to accelerate the scientific discoveries and to promote innovative scientific technologies. And I think that has been achieved up to some extent because more than 1,000 conferences and the scientific events have already been organized since its inception. And not only in US, but in other countries, in other continents such as Europe, Asia Pacific, South, so on. And today's event is the part of that major activity in this brief existence of the Omics International Conferences. The theme of today's conference, that is pain, approaches to predict, control, and relieve. That has been, I feel that it is very much relevant to today's era, which is the cyber era. You know that we can get everything, almost each and everything with just a click on the mouse. But every coin has two aspects. And this is also the another aspect, that is, it has given us the sedentary lifestyle. And because of that, we are on different kinds of pain. Some has neck pain, some has back pain, knee pain, shoulder pain, so many types of pains. And that is being very common. The prevalence of these kinds of pain is being increased day by day. And therefore, I feel that it is indeed the need of the hour to discuss about the kinds of pain, to discuss about the factors which can help in controlling the pain and in relieving the pain. But before that, if we can do this or that, not that, we should know about the predicting abilities of the pain or the different kind of disorders. And for prediction, we should know that how to build up the prediction model. What are the different strategies to build up the model? And if we are able to build this model, then we should know that what is the specificity, so what is the sensitivity of this model. And for that, I think that the conferences like this is the correct platform to have the scientific deliberations, the informative sessions, and to share the research experiences. And therefore, I feel that this event is going to be the successful event. And I thank all you for sparing your valuable time and the organizing committee members for making this event. Now I'll introduce you with the worthy guest of our conference, and I request them to come onto the dais, to grace the dais immediately after my introduction. At the outset, I would like to invite Dr. Mark Varsavel, who is the principal at Visenium LLC, USA. Sir, please take your position on the dais. Thank you. Next, I call upon Dr. Grant, the caring doctor from World Organization of Natural Medicine, Canada. I suppose he is not there. Now I call upon Dr. Michael J. Indarola, who is the senior research scientist from the Institutes of Health, USA. Unfortunately, even he is not there. Next, I call upon Martin Grabois, who is the professor from Baylor College of Medicine, USA. Anyways, okay, now we'll begin the keynote forum, and the first keynote speaker is Dr. David J. Nagel. I invite him for delivering the keynote speech. But before that, I'll say something about him. Dr. David Nagel comes to the field of pain management, specialist in physical medicine rehabilitation. He has been practicing pain management from last about 27 years, and he has been heavily influenced by the experience of his own mother suffering from the rheumatoid arthritis. From her, he learned the importance of a patient-centered plan of the care on interdisciplinary cooperation and continuous He also learned how patients suffer needlessly when this does not happen. His experience led him to a role of social advocacy, and he is the founding member of the Pain Management and the Prescription Drug Abuse Task Force for New Hampshire, and he is the current chairman of this organization and a member of the Pain Action Alliance to implement a national strategy. He has given numerous talks on this subject. He is also the author of The Needless Suffering, a critical look at pain management in America. This book is going to be released later in this year. Sir, please come and deliver your speech. Thank you.
Wait, time that raised. Bing. All right, we're on. Yay. So, something really wonderful happened last night. I was watching late night and the channels and all that stuff, and I came upon a channel that said, "Problem solved, chronic pain is gone." And I found out that treatment for chronic pain that eradicates. So I guess we can all go home. Wicked Witch is dead, and we can go back to our homes. So that's exciting, so I'll see you later. But it would be absolutely wonderful if there's some cure for chronic pain that's lurking in these back channels of the internet, or we really know that that's not true. And what really bothers me about things like that is that advantage of people that are very vulnerable. And it bothers me that it's not just those people lurking in such dark shadows that are doing that. And that's kind of the focus I want to talk to today. I'm really excited to hear the things that you do. Pain 2015, we're going to learn all about, the latest and the greatest in pain management. My job, as I see it, is not so much to do that, but basically to tell you everything that you probably already know. And maybe, hopefully, I can do that, make you think about things in maybe a little bit of a different perspective. I like to quote two of my heroes to start with. As many of you know, Mother Teresa worked in what she liked to call the poor throughout her entire life. And what you don't know, maybe don't know, is that Pope John Paul II did the same. They basically saw value to all human life, and what is not known about either one is how much of the two of them actually had to suffer throughout their lives to accomplish the things that they did. Mother Teresa felt that loneliness and the feeling of being unwanted is the most terrible poverty. I've been doing pain management for 28 years, and I've really come to see pain is to the medical world like poverty is to the soul. And the people that we see are stigmatized, ostracized, often abandoned, it's a problem, and they suffer because of it, oftentimes unnecessarily, just because of our actions or the actions of those. What makes things even more difficult is Pope John Paul is, despite everything that's going on, we're not free to eliminate the world from suffering. It's part of life. It always is, always will be. There will never be a magic bullet that's going to ever change that, no matter what we do. But as we all know as pain specialists, nociception and suffering are not the same thing. Into this world steps me. Who am I? My original focus in medicine was not pain management. The only thing I ever wanted to do when I was in high school is I was interested in functional issues at the end of life. I worked at a cancer for 2 years before I went into medicine, and I was struck by the focus on 5-year survival, but not the focus on what's the quality of life in those 5 years. At that time, the hospital I worked at had focus on that. So I was going to change the world. That was going to be my only goal in life. I went into physical medicine and rehabilitation, and that was, and unfortunately, you know, as the world goes, take us into ways widely divergent from what we planned, and I ended up not doing that, although interestingly, as my career winds down to its end, I'm actually going back to doing that kind of thing. But I went into physical medicine, and nobody ever taught me in physical medicine that treating chronic pain was part of that. We didn't really learn it in residency. We only learned it because we had to, because everybody kept sending us all these patients that they didn't know what to do with back pain or nerve pain or whatever. So I thought it might be a good idea to learn about that. So I kind of did it on my own after hours, and a bunch of my other residents did the same thing. So the first job I got, I come to New Hampshire, and I didn't realize that the Messiah was coming to New Hampshire. Every doctor in New Hampshire was all excited that I showed up, that I could take on their patients that they had no clue what to do for, and little did they know I wasn't sure I had a clue what to do for them either. But that's what I've been doing. I actually work with an orthopedic group, 22 orthopedists and me, which is kind of entertaining. For the first 15 years of my career, I did pain management, comprehensive, from soup to nuts, the whole thing. Beginning in 2003, they informed me that they wanted me to be an interventionalist. I mean, I've been doing interventional pain since 1987, so it wasn't like a big transition for me. But for it to become my whole practice was something I have really struggled with. I have a real problem with it. I really hate that term interventionalist. I think it's wrong. I used to work with patients for days trying to help them to adapt to a challenging problem, and that's not an intervention, but me sticking a needle in with somebody that I haven't met and I may never see again as an intervention. I struggle with that. I never meant to be a social advocate either, but my son drove this for me. He was kind enough to give me hair. I don't really have that much. But one of the things I'm really bad at is missing the elephant in the room. And I put a $sign on the elephant, but there's a lot of elephants in our room that we miss. And the first elephant that we saw was in the late 90s when, with opiate policy changing, I was struck that our state, New Hampshire, did not have an opiate policy. So what I decided to do was send an email to a friend of mine to figure out how do we address this. And it was 1998, the internet was relatively new, and I had no clue what email was. And I didn't even know I hit send. About 2 weeks later, I get a call, congratulations, you're chairman of the opiate task force in New Hampshire. So ever since then, it's been a series of volunteering for things and trying to make the world a little bit different. That led me to this, Needless Suffering, a critical look at pain management in America, which is coming out next year. This did not start out as a book at all. It started out as a catharsis, one that we probably have all dealt with in our lives. You're going to meet Jane in a second. She's one of my patients. But Jane was, and that's not her name, obviously. But anyways, I was just struck by how horribly people could treat somebody who's suffering so much. And, I was always taught that if you're really feeling to just write about it. And I've written hundreds of short stories. I only write stories. And I went back and I sat down in a room and I didn't leave it for 3 days. And I guess I was so upset that I wrote a 100-page manuscript. And when I was done, I shared with mine, who has chronic, actually also a patient. And when she got done reading it, she read it in one night, calls me back, and she says, "You have to publish this." And I said, "Why?" publish anything. I just share small groups, things like that. And she said, you have to publish this. You're speaking for us, she said. And so I said, well, you know, this is really abstract. I think most of the world won't understand it. We need to make it concrete. Ended up doing was, this is a sociological perspective on pain in America, how we treat pain, and look at the big picture, not the family, you know, provider picture, but actually from all the different entities in our culture that have the ability to help or harm those who suffer. And my criteria of reference is very simple. It's the golden rule. How do we treat others relative to how we wish to be treated? It seems so basic, but what I found out when looking at different professional ethos is that no matter you know, what background you're from, whether it's faith-based, business-based, or whatever, all of our ethos start and end with the golden rule. So that's what I use. What do we say? What do we do? What's the gap between the two? And most important, what can we do better? The final chapter of the book was the most important to me, and it's called Am I a Coward? And there's a question mark at it. Because I personally feel that I'm a hypocrite by giving up chronic pain, comprehensive pain management, to bow to the socioeconomic pressures that we feel, to just do purely interventionalism. And I had to come to an answer to myself. Am I a coward or am I not a coward? And I think it's a question that we all know about. We're not going to talk about all these 5 steps. They gave me like to come up with an abstract, but I want to talk about. And this is what's in, you know, that I discussed, but the first 2 are the 2 I want to concentrate on, because I think they're really important questions. What do we mean by pain management, and who's part of the team? The other ones, if we can get to, great. If we can't, don't worry about it. First, let me introduce you to my teachers. I learned from everybody. I remember learning from some homeless person in New York City years ago, and that person changed my life just because I took 5 minutes to listen to them. But that frightened me. But anyways, George Engel was, I don't know how familiar with who he is, but he's the gentleman who created the biopsychosocial model of medicine. I went to the University of Rochester for med school only because he was there. I was convinced of the importance of doctor-patient communication as the most important tool in helping us do what we do. And that was the way he felt. And in creating this model, he said that whenever you interact with a patient, there's all sorts of stuff going on that you can hypothesize and make decisions, clinical decisions based on that can make or break how you treat somebody. And he was looking at psychologic factors, social factors, so on and so forth, and he said that it's all important. And that really excited me because I saw that in my own life, which we'll get to in a second. But I think he would be struck. You know, he passed away in 1999. I was one of his last students, and I was really honored that. To see how much we are so focused on technology and so not focused on actually listening, touching, feeling patients. And so many of my patients say, God, the doctor never even touched me, you know, stuff like that. He didn't listen to me. He was so bent on getting everything into that computer that he never listened to a word I said. I hear this every day, and I'm sure a lot of you do as well. But this is mom and dad. That guy on the left's me when I had hair. I learned more from them than I learned from everybody. We don't have a pointer. Oh, do we? Yeah, we do. I don't know how to work this, but does that work? Never mind.
Yeah, the button works. It's one of those 2 little buttons.
Oh,
You're probably pointing it at yourself.
there it is. Okay, this is my mom, that's my dad, that's me. This is on my wedding day, 1988. And I remember that, and I remember my anniversary day. I never get in trouble. So that's the secret for a happy life. Just remember your anniversary date. This is my mother. My mother had rheumatoid arthritis, was diagnosed when she was in her early teens. You can kind of see already, this is a long time ago. She passed away 7 years ago, but you can see she's a little bit, you can't really see her ankles, but her hands, her feet are grossly deformed. By the time she passed away, joint in her body was grossly deformed. It was really hard to watch. especially as a pain specialist, knowing that there's not much you can do about it. I mean, there's stuff you can do, but the other thing, look at her face. My mom always had a smile. You never, ever saw her without that, and that's all anybody ever commented on. In fact, my mother-in-law knew my mom for 4 years before she realized she had a problem because she was so busy looking at her smile. And she also treated people wonderfully, and the reason why I bring our society has this view that chronic pain patients are whining, miserable people. Most of them are more like my mom. They're hiding what they're really suffering from. They suffer in silence, and a lot of times they think that nobody cares about them. And it's a real problem. That's my dad. My dad loved my mom. He took care of her whole life, especially at the end when she was totally dependent. He was always there for her. And the reason that's important is the importance of advocacy, of somebody to be there. So devotion. The other thing that you can't see in this picture, she had the same rheumatologist for 35 years. I don't know about other countries, the United States, that's almost becoming a thing of the past, which is really sad because if she didn't have that rheumatologist with her for that long, there's no way she would have lived to be 80. This is me, that's that. One day I come home from my residency, I'm so proud of everything I've learned about pain management, all our great breakthroughs and everything. I come home and I tell my parents everything that I learned because I like to tell them stuff I learned. My dad looks at me like, yeah, like, duh. And I finally realized that I'd been living with chronic pain my whole life and I never saw it. And it just struck me in our culture, it's all around us, people don't see it, we trivialize it, we pretend it's not a problem. And I'm saying we is not us, but because we know everything. But anyways, the last thing was this. My dad died about 3 months ago, and he was at the last couple weeks of his life. And my dad was a miserable SOB. That'd be the politest way to say it. Really stubborn. He was a pain in the neck. He was always right. Nobody else was right. And the staff was totally split on how to take care of him, and it was very dysfunctional. But the minute they wrote that hospice order, all of a sudden on the same page was wonderful. If death can be wonderful. And it just struck me how important cooperation was. Jane, where are we now? I have no idea where we are in time. Do you know? Okay. Give you a brief overview of Jane. Jane is a patient we see every day. Jane herniated a disc, had surgery, did great. Went back to work. Like 20% of people with herniated discs, she reherniated. And all of a sudden, they again, this time it didn't work so good. She got infected, she got developed RSD, what we now call CS, and she was miserable. Then she comes to see me. We basically were able to get her functional with a very minimal regimen, physical therapy, regular exercise, get her out of the house on a regular, which was good for her brain, and Percocet, 1 every 4 hours. And this was in the late 90s, so things, I guess, would have changed a little bit by now. But I kept her on that regimen for several years, and she did great. Then all of a sudden, out of the blue, she did something I've only seen twice in my career. She reherniated a 3rd time, same level, but this time she had caught Aquinas syndrome. Bladder problems, difficulty walking, but one of the missing stories about Jane was that she was so traumatized by how she was treated in the hospital after the 2nd surgery, she was scared to death to go back. She sat at home peeing her pants for the next 3 weeks, afraid to go in and see a doctor. Finally, she calls me, get an MRI. She has a massive herniation. And I said, you got to have surgery. I have to do something about this. And John Kostowicz, being quite important, sometimes people with cauda equina get better without surgery, and she did. Amazingly, she got her bladder function back, her motor function back, but her pain was worse than it ever was. And I should also throw in, this is a workers' comp case too. Jane liked to do 2 things. She liked to go out on a somewhat regular basis, which was a hard thing for her to do, and it was much harder now. Mow her lawn. 30-minute mowing her lawn and a riding mower once a week was therapeutic for her. I asked for her to be able to get a community or a scooter for community mobility, and insurance company put who I like to call the claims adjuster from hell on her case. Adjuster, I'm going to simplify this and shorten this, but she made her life miserable. She had her private eye. She took her to labor board hearing after labor board hearing. An easy problem to manage suddenly became almost impossible. The long and the short of it is she attempted suicide several times, so on and so forth. I only have 5 minutes, but I'll just finish on Jane. But anyway, so I was just amazed at how the actions of one person could be so destructive. She's now divorced. I know she's, but I haven't seen her in years. And what I became interested at the point was the actions of other people outside of doctors can adversely affect somebody who's suffering from chronic pain. I'm just going to finish on this, and then I'm going to conclude. What exactly is chronic pain? And I'm just going to leave a question to you, because this discussion could go on for this up at the American Pain Society. What you and I believe to be chronic pain may differ, but it's important that we're all on the same page about this, because patients have a point of view that they're coming us to be cured. But that's not what we can do. We don't really have that ability. We have lots of things in our armament in the long run, and we don't really cure much of anything. What I've learned about chronic pain years is that we're better at treating mice than people, and I told that to a mouse in my house the other day. I looked right at him, he says, if you have pain, I can treat you. And he was all excited and ran off, and then we killed him because that's what you do to mice in your house. There's no universal understanding of pain, there's no universal solution as of yet. There's no cure, and every patient's experience. In the short term, we do a lot of great things for people, but in the long term, that's not so clear. That's Bill. I saw Bill about 5 years ago, did a couple epidurals on him. He did great. He wanted his problem fixed. That's what they did. Now he's miserable. Came back to see me. Sometimes things that our greatest intentions don't work out. So the other thing I want us to learn to focus on is pain's a moving target, and it's not just because of neuroplasticity. It's because people grieve their loss of function. Pain's a really miserable thing. Chronic pain sucks. Pain is the most Lord of all mankind. It's much to say that. But anyways, people have to learn to adapt to that, and they go through a moving process. They're going from time to time, thing to thing, and it's always changing. Every time they come in to see us, things are going to be different. And we need to learn to accept and understand that, but deal with that as well. Chronic pain management is just helping a suffering fellow human adapt to a permanently altered, unpleasant, and new reality. How are we doing? How much more time? 3 minutes, good. So this is what I've come to the conclusion of, is that you need to take a chance to believe these patients. I had a patient come in the other day that she told me, I mean, she had a very legitimate problem. She was accused of drug seeking, all sorts of other things. She's a high-functioning person that was hardly taking any pain medication. All I did was listen to her, believe her, accept her. She ended up doing very well with treatment, and now she's off her pain medicine. A lot of people are like that. And she came back and saw me just before I left for here, and she said, you were one guy, and because you believe, she said. It's very empowering. We be honest about what we can and cannot do, and I think that's huge. I brought this up at the APS, American Pain Society meetings, in our ethical section about we really need to be honest about what we can. Realize we're sorts of people that claim they can do things that they can't. Most of the rest of this is stuff that we know, but teamwork's essential. The best teams are the people where everybody's on the same page, they're working together, and they're not afraid to show tough love. Tough love is constructive, it's not destructive. You're telling someone, man, I want to hear. That's for their own good, but you don't abandon them. You stay with them all through the process. The opposite is criticizing them, calling them names, and then transferring them off to another doctor. And I just want to finish by saying, this. Two things. Integrity is doing the right thing even when nobody is watching. Every day, before I go into every patient encounter, I always take a deep breath. put my thoughts outside the room and walk in, and the only person I'm focusing on is the person in that room. How can I help them that day? And what I learned from Mother Teresa, she was asked how to solve the problem of homelessness in Washington by Sam Donaldson. She answered, help the person nearest to you, but one by one, and start with the person nearest to you. And that's what we try to do every day. That's it.
Okay, morning everybody. Thank you for the organisers who invited me to speak. I just want to get a bit of an idea from what types of doctors we've got in the room. So are most people doctors or researchers? So just hand up for doctors. Good. Okay. And excellent. All right. Now, number of doctors, pain medicine specialists, right? Psychiatrists, palliative care, right? Rehabilitation specialists, neurologists. All right. So, a neurologist, rehab specialist, and a pain specialist. So, as you heard from my bio. And so I've been doing a little bit of both, little things. And so what I'm trying to talk about today is a little bit of more chronic pain management in terms of an Australia. And so this is Australia, which are a lovely harbour bridge, and a few of my disclosures there from some of the companies. Some medications as well, and hopefully you'll have or know those medications from around the world as well. From the last speaker, I mean, I have no idea what Percocet is or whatever that particular drug was, but hopefully there'll be some drugs in here which are very similar to what you all have around the world as well. Now, the most important thing, of course, is with neuropathic pain, we see it all in our practices all the time. It's very, very under-recognised, I think. A lot of people who come to us in our chronic pain clinics, they pain, and it's the first time that people have come to us saying, well, I have no idea what my pain is coming from, and we diagnose them with neuropathic pain. And so about 25 to even 50% of people have neuropathic pain, and they would never been recognised that prior to them coming to us. The reason for why it's so difficult to manage is, of course, lots of different mechanisms which are involved. There'll be some people who say it's central sensitization, then there's peripheral sensitization, there's nociception, there's the sympathetic overactivity, there's factors which come into play. And it's such a multiple mechanism which are involved, and there's not one drug or one particular management which can fit all of those particular things. As a result of that, it gets very much undertreated. And the problem is all of our medications and all of our other treatments we have, they only have a modest effect in reducing pain. And of course, from our first speaker, we've talked a lot about the biopsychosocial model. And I think that's very, very important when we're talking about all of our treatments and all of our management of all of our patients. I hear a lot of people who say that they can treat or cure or manage people's pain really, really well with one particular type of interventional therapy or one particular type of treatment that they might be able to. And, I think that might happen for one or two or three or maybe even 10 of your patients. A day you'll have so many people who have gone to see this person and that person and that person, and they've said, oh, I'm going to cure you and I'm going to make you better and you come and see me and, you'll be right. But at the end of the day, there's so many come into play with chronic pain patients, and that's why they're going around and seeing one person after the other. Because people are just trying to address the biological and the perceptive type factors and all of the more of the chronic pain factors, and they don't really deal with the logical and the social factors. And it's very, very important to say, okay, we're going to put it all together and trying to deal with the whole person together. Where it's all coming from is obviously we have to have this multimodal approach. And again, we talked about that in the first talk as well. In this particular talk, we're going to talk a lot about the pharmacological factors, but I'm not going to stand here and say that's the be-all and end-all of chronic pain management. We all know that that's not going to be the case. The physical therapy is all that you have to do. You have endless amounts of chiropractic therapy, endless amounts of physical therapy, and then they continue not to, as we all know. Then the other people are going to come and stand here and talk about things and say, I'm going to do this to someone, and that's going to be the be-all and end-all of their chronic pain. And I think it's important to just put all those things together and say, okay, these are all options that we have available, and then you need to start saying to yourself, we're going to think about this option, we're going to think about this option, but have it all together in the whole person. Quite interesting that even though we all feel as though we treat neuropathic pain really, really well, when you look at the types of drugs that are used, most people don't even use the appropriate drugs as first-line therapy. Now, in this paper back in 2007, it was amazing that most people for neuropathic pain, they use things like paracetamol and non-steroidals as their first-line option for neuropathic pain, even though I'm sure everyone in this room is aware of anti-epileptics and antidepressant medications. But, nearly 7% had paracetamol as first-line therapy. And that's the reason for that is because a lot of people who, when they first get pain, they don't come and see pain specialists as their first line. orthopedists or surgeons or other general practitioners, people who are scared. They are very, very scared about using antidepressants and anti-epileptics as first-line therapy. And you see that in people in general practice all the time. I get so many people who will not take a very, very small dose of amitriptyline at a dose of 10 milligrams because they've been their pharmacist that mad because they put you on an antidepressant. I mean, I'm sure you get that all the time when people, they'll come back like 2 or 3 weeks later and say, I didn't take your drug because you put me on an antidepressant, and I'm not mad. You know, and then you have to explain to them all over again that you put them on a medication to try to reduce the neurotransmitting effect. But the difficulty is that even though we might have these drugs, they're still not that effective. You know, we keep on thinking to ourselves, oh, we're going to put you on something and it's going to help improve your pain. But really, I mean, what are the numbers needed to treat for most of these? They're not really that great. But the important thing is you have these options available. And you have to have all of these things in your armamentarium to try and help improve things. So these are like the NNTs for we have. And you can probably see from there that a lot of the older drugs have got better numbers needed to treat than the newer drugs. But the amazing thing is, what are we all using around the world nowadays? We're all using the newer drugs. Okay? I mean, first-line therapy in Australia anyway is pregabalin. Anyone around the world, I mean, if I took a whole room of people here who say, okay, if someone comes to you with neuropathic pain, what's the first drug you're going to use? You know, I'd say 30, 40, even 50% of you will say first-line. But still, amitriptyline and carbamazepine have still got the evidence to say that they are most effective medication. Why we don't use them? Because of the numbers needed to harm. That's because people don't know how to use them. There are still so many people, even in Australia, and I'm sure all around the world, when they start amitriptyline, they'll start with 25 milligrams. Why do you need to start with high doses just because someone comes to stress and they think, oh, my pain is 10 out of 10, therefore a doctor has to give them a huge dose to start off with? You don't need to. Start with low doses and work your way up. Then people will a lot better. And you can use it in elderly patients as well. So I have lots of people who I start on amitriptyline milligrams. I have people I start with Tegretol starting at 100 milligrams at night. You know, and they tolerate it, and at least they're not missing out on a drug that might be very, very effective for them. As you all know, there was a period of time there, we all started pregabalin at 75 milligrams at night. Or even some people would start 75 twice a day. That's what the recommendation was, right? But now, most people are now starting with 25 milligrams. Yeah? Gabapentin or started at 300 milligrams, even a day. Now we're all dropping down to 100 milligrams, okay? People are getting smarter, and then people are tolerating it better, and people are able to continue with their medications. So I think it's really, with the lowest medication, work your way up slowly. Every single time a new drug comes on, they come and say to me, you can increase the drug every 2 or 3 days. Why do you need to do that when people have had chronic pain for 10 years or 5 years or 2 years even? Their doses up slowly. I usually go up every 2 weeks, not every 2 days. Let them get used to the drug, let them tolerate it, and then slowly. I'm sure I'm telling you, all of you guys, what you guys already know anyway. But the thing is, I think it's important to reinforce that type of... Even I see so many people who are coming to me from other specialists who are basically saying, I failed this, I failed that, I failed that. But why they failed it is because those people have started them at too high doses, or they've escalated their dose. And it still happens. Anyone get it, where that is? Surprise, Sydney. And that's the Sydney Opera House. All right. This is obviously our WHO analgesic ladder. And I've put Australia there because I have no idea whether a lot of these drugs are available in other parts of the world as well. And of course, this is for pain. You work your way up slowly, start with the weakest medicine, and then work up to the stronger roads. Amazingly, we always tend to get our drugs very late in Australia. Right up in the strong opioid category there, tapentadol, which I'm sure you guys have had around the world for a long, long time. It only came into Australia about 12 months ago. So it's one of those things that, you know, we let it with all the problems first, and then Australia then decides, okay, now it's like, so we'll let you go. Now, with neuropathic pain, again, put Australia up there because I have no idea whether a lot of these drugs are available in the rest of the place around the world. Again, the reason I put this up is because it's to show a lot of people that there's not just one drug or two drugs or three drugs that is you can use in patients who've got neuropathic pain. Because a lot of people will come to me and say, oh, I've tried pregabalin and now I've got nothing else that. But the thing is that every single anti-epileptic medication that's out there has been used for neuropathic pain or has a role in neuropathic pain. And I suppose me as a neurologist, I feel a bit more comfortable using it because I've used a lot of these in epileptic patients. But there's no reason a lot of these medications can't be used in patients who have failed your conventional other medications as well. Used to saying, okay, you know, they've tried this, they've tried that, then every time a new medication comes on board, you can say, oh, well, look, now I've got lacosamide, now I've got zonisamide, now I've got this, now I've got that. It's a way of feeling comfortable using drugs. And if you start with, then you'll start, well, maybe I can start using it, and then say, okay, I've got nothing else to offer because I do have other medications now becoming available in whichever parts of the world you're practicing in. Okay, so right up the top there's a few drugs which we don't have in Australia yet, such as retigabine, but I'm sure you may have them around in other parts of the world, but they haven't come to Australia. But at the end of the day, we still have our Australian Pain Society recommendations, and we're still at the stage where we're using the noradrenaline antidepressants, triptyline and duloxetine as first line, with the gabapentin and pregabalin as the first line agent. So they're trying to say that you can use one or the other, and when you start talking to the people about why you're putting pregabalin and amitriptyline on the same page, they always say, well, people should have a choice because they have to decide which patients can be used for one compared to the other. But like I'm trying to get across is that every patient can really tolerate amitriptyline if you start at a low dose. So there's no reason why they couldn't say you should use something like amitriptyline first line, and then if they don't tolerate it, then you go to something like pregabalin. It's missed quite a lot. Valproate. Now, I don't know whether a lot of people in the room tend to use pain practices, but the thing is, because there have been no really good trials done on sodium valproate, we don't tend to put in any guidelines whatsoever. And the thing is, it's a lot better tolerated than Tegretol or carbamazepine, and it tends to work effectively. There was one trial done which showed the NNT was 2.3, and when you try and get the company trials on it, they say, well, what's the point? It's a cheap drug anyway. We don't need to spend any money on doing trials on it. But there's been so many anecdotal evidence to say that it's effective. And so this was just the case that I had of trigeminal neuralgia who'd had pain for a long period of time. And she tried the usual Tegretol or carbamazepine. Then she went on to try pregabalin. And so as a third line, we tried sodium valproate on her. And just a very small dose of 200 milligrams reduced her pain from 6 down to 4. And then increasing it up to twice a day, she was virtually pain-free. And the amazing thing was she continued to be pain-free for the next 5 years. And so this was someone who'd had pain continually on and on and on for a long period of time. And she was actually thinking about going for decompression surgery, but responded very well to a very small dose of sodium valproate. And so there is this new stereoisomer, which I think has been designed more in the Middle East, which may be becoming more involved in clinical trials of similar to sodium valproate. And because it's relatively new, there'll be more trials done on that, and therefore role in the management of neuropathic pain down the track. because of all the problems that people attribute to carbamazepine, as we all are aware, there's also oxcarbamazepine as well, which is the metabolite of carbamazepine, and it's a cleaner drug, it's the metabolite of it, and therefore the side effect profile is better. And so it has less nausea and vomiting and dizziness and lethargy. And again, it's as effective as carbamazepine as well. In Australia, we've got one of those things where government pays for certain drugs and other drugs they don't pay for, depending on the condition that the patients have got. And so we'll cover the cost of it. If people have pain, then the patient has to cover the cost. And so a lot of patients depends on things like that. Even if you're a pensioner, money whatsoever, if they get put on this for pain, they still have to fork out the money. So in Australia, this one costs about $90 a month. So it depends on whether patients can afford to buy it. But that's why there'll be absolutely no way I can't afford to go on it. And so elderly patients can sometimes miss out on a drug which is going to be quite effective. So this was an lady who, again, had TN, diagnosed a long period of time ago, responded really well to Tegretol or carbamazepine, and then had a recurrence of 20 years later. And so because she was 88 at the time, it was that carbamazepine, probably because of her age, it may result in giving her side effects of drowsiness and confusion. The local doctors tried her on gabapentin instead, but gabapentin didn't help at all. And so when she came to see me, I thought, well, why not? Because she did so well on carbamazepine, let's try her on oxcarbamazepine, and it did a wonderful job for her. So those different options available and saying, okay, you can try this or try that. And then how many of you have used lacosamide for pain? Anyone in the room? Yes? You find it effective? How many people have you tried it on? So again, the reason why I think lacosamide is also a potential use for neuropathic pain is because it works on sodium channels. So theoretically, it should work on neuropathic pain as well. So because it works on a similar effect to what carbamazepine does. And it works on the slow sodium channels. And it also has some effect on calcium channels as well. So it does some effect on how pregabalin works as well. But because there have been no trials done on lacosamide in pain, that's why there's no medical evidence for it. But again, there'll be certain patients who respond to it. And so when you've had people who have failed this and failed that, and you're thinking, well, you don't want to send them off for surgery, you don't want to send them off for any invasive procedures, then there's no reason why, okay, well, there's another medication that may be potentially worthwhile to them. And once you get used to it, because we use it a lot in epilepsy, then we can also use it, we've got some experience using conditions as well. Very busy slide, but basically what it says is that an 82-year-old man who had burning in the soles of his feet for 20 years, nerve conduction has confirmed that he had a peripheral neuropathy, and he tried so many things. Carbamazepine, amitriptyline, phenytoin, and clonazepam. So already 5 things he's failed. All right. Then he'd gone on to gabapentin, then oxetine as well. So everything that you would normally be using in your clinical practices. And then I even tried him on levetiracetam, which is Keppra, and then oxcarbamazepine as well. And then finally we said, okay, he's failed a lot of these things, and it was around that time when lacosamide was starting to become used in epilepsy. And so with that, he tried that, and that reduced his pain down to about 1 out of 10. So what this is basically trying to show is that even though people fail 1, 2, 3, 4, 5, 6, 7, whatever, it doesn't mean that people do absolutely everything in a lot of cases. So there are lots of people who I've got with TN, lots of people with peripheral neuropathy, lots of other cases where they may fail. As long as they're continuing to keep coming back to see a person like me, I've got other things that I can continue to keep on using to see whether we can help improve them or not. And zonisamide is a newer one which has recently come on the market. Again, blocking sodium channels. So again, similar to working on how Tegretol works on. And so potentially has got the same, should have an effect on neuropathic pain as well. And like I said before, tapentadol has only recently come into Australia as an analgesic. And because it works on the mu-opioid receptor, plus it works on the noradrenaline reuptake inhibitor, therefore it's got effect on both nociceptive pain and neuropathic pain, so mixed pain. And as we're all aware, there's lots of patients who have both types of pain. So a lot of people will describe their pain as darkness and pressure type, and also as the sharp and shooting and burning. So, you know, this is quite an effective tablet for those types of people. Okay. Then, of course, we also use other interventional things. So botulinum toxin. It's become a chronic migraine. And I saw something on the TV this morning about an ad on chronic migraine in America. We've had it in Australia for about 18 months for chronic migraine. We can also use it off-label for a lot of other conditions as well. And I've facial pain, so people with trigeminal neuralgia. Again, off-label means that patients have to pay for the Botox, which I think, you know, a lot of people around the world do as well. But again, in certain conditions, it can be quite effective. So what I've been doing is injecting just below the zygomatic arch and also into trigger points into the face as well. And then finally, there's the new patch which we've now got available in Australia for post-hepatic neuralgia. I've also used it in other conditions which are not just post-hepatic neuralgia. So people who have got thoracic back pain, even with lower lumbar back pain as well. So it doesn't have to be just from post-hepatic neuralgia. And so because it's got the hydrogel, a bit of a soothing action, and also it's got the lignocaine working on the sodium channels as well. So it's got a dual mode of action. And so it's just another option for patients who have, you know, either have medications or have maybe responded to local anaesthetic injections and may respond to the patches. And then finally, we all are aware of wind-up and central sensitization. And I will be giving a talk on Wednesday regarding the use of ketamine. So we've been using sub-anesthetic doses of intravenous ketamine and following that up with lozenge. So I did put that into this presentation as well. I've been using it in lots of different conditions. So anything to do with some type of neuropathic component to their pain. So CRPS, chronic peripheral neuropathy, trigeminal neuralgia. We've got lots of different gamma who have had any forms of chronic neuropathic pain. But generally, it's reduced the pain by around about their analgesic requirements as well by about 48%. But more, I'll go into more of that on Wednesday. So overall, what I've been trying to get across is that even though chronic pain is very, very difficult to treat or under-recognised, I think it's important to be aware that there's lots and lots of different options that we have available to us in our day-to-day lives. I come from obviously a medical background, therefore I'm dealing with a lot of medications that we tend to use. Okay, what can I use in this condition? What can I use here? I think it should be used in a multimodal approach, so that you can use the medications here, but then you've also got the psychological factors, you've got the interventional things, and then in a chronic pain faculty with the cognitive and behavioural pain management as well. So I think that we should just put it all together, and then hopefully then we'll have better outcomes for our patients in general. So it's always just looking into a crystal ball, really. I mean, I think you're not going to treat everybody the same way, and I think it's just seeing how to individualise the treatment of patients. Very much.
Here we go. Here we go. All right, we do have time for some questions, so if you have a question, please raise your hand. I'm going to bring you the microphone. Questions?
I deal directly with patients. Ketamine and arachnoiditis. Australia knows the issue with arachnoiditis.
Yes.
Are you using ketamine on infusions, and what are you finding there? Are you getting a good result with that?
So in our group, we had about 3 patients who had arachnoiditis and did quite reasonably well. So the ones with arachnoiditis, they were on huge doses of morphine prior to the ketamine. And I think they were the 2 who were on about 400 milligrams of OxyContin per day. And they were able to reduce their doses down by about, down to about 50 milligrams per day after the ketamine.
What about ketamine in children? We have an increasing number of children acquiring arachnoiditis.
Okay. I haven't got any experience in children, unfortunately. So our chronic pain clinic starts from 18 onwards.
Okay, good.
Any other further questions?
Yeah, thank you for this.
Yeah. Lights on.
So thank you for this excellent overview of treatment options, and I think it's good to hear that there are options than the usual treatments. And so you mentioned number needed to harm and number needed to treat, but I think from your approach of just gradually increasing dose, you find that it's actually more important to find the right dose for a patient that's just between harm and has the treatment. So.
Yeah. So my approach really is that I use small doses of different medications.
Yeah.
So I find that if I work my way out slowly, as dose possible, increase it every 2 weeks, and then if I don't get a good response, say with drugs like pregabalin, I tend not to go more than 150 twice a day. Then if rather, I know a lot of people in the room will go 300 twice a day and even go higher than that, but if 150 twice a day is not really working, I will add a second drug at a lower dose. And I find synergy working on different mechanisms, they tend to work better than having one dose going up higher, giving side effects.
And there are very few studies that actually have studied those synergisms.
Yeah, yeah. And that's why, I mean, a lot of things may not be medicine, but in clinical practice, you have to treat the individual patient which is in front of you. I'll have patients who are on a bit of duloxetine in the morning, amitriptyline at night, and then be, pregabalin as well. So 3 different drugs, but small.
Yeah.
Like even my amitriptyline, the maximum dose is milligrams. Don't go any higher than 25 milligrams.
Oh, God.
So I note that Vigabatrin, one of your slides.
It was a long time ago.
It was a long. I was wondering what the status of that.
Once the visual field defect came along.
I see. Okay.
Then it went away. But at one stage it was used.
Right.
Excuse me. I was just reviewing the neuropathic pain treatment. In fact, it is not just one drug to the other drug. I think there are about, for me, I just review about 6 or 7 different guidelines that based on the systematic review. I think the United States and in Canada, or even in England, like they are using NICE. So in Australia, is there any specific guidelines? Are you following a specific of the treatment?
Yeah, the guidelines apart from the Australian Pain Society, which is that guideline that I put up there as part of it, which was this one there. Yeah, that even this from 2008, we were thinking about changing it even for 2015 when the market, but still they felt as though that was not going to change. That this is still the guideline even today. The thing is, as you know, in clinical practice, guidelines are to guide a clinician. But in clinical, when you've got someone sitting there in front of you, then you have to individualize it. And so that's why it's important. Okay? And so that's why, I mean, unfortunately, when you have guidelines like this, every single person goes off and starts using pregabalin as first-line treatment. Right? What the numbers needed to treat are still 4.5.
What is the cost?
Yeah, the cost of amitriptyline is 2 cents. Okay? It really is 2 cents a tablet. It's still around about 40 or 50 cents. So the cost is still, the economic cost is still very, very small. Yes. The microphone behind you.
Good morning. Congratulations for your specialization.
Thank you.
And my question is, what's your experience about lamotrigine.
Yeah.
Lamotrigine. Your
So-
personal,
Yes.
please.
So, from a neurologist point of view, I find lamotrigine to be difficult to use because of the rash that a lot of people get from lamotrigine. From a pain point of view, I think it is an effective medication to use, but the logistics of using it becomes very difficult. The interaction with lots of other medications and things as well. And I find that I don't tend to use it in my there was one to see a lot of people being put on it, and I was seeing the actual pain specialist using it was starting at 25 and within 3 days going up to 25 twice a day. And not surprisingly, they ended up with Stevens-Johnson syndrome very soon after that. So they were just going up way too quickly. And I think that there's a lot to use out there than lamotrigine. I have no problem. It's on my list, but it's not one that I tend to use because I find other drugs to be more effective.
Ziad Al-Shami, Saudi Arabia, I would like to thank you very much. We all get worried when we hear a lecture like that. We think it's going to be boring, but you
Yes.
did it very well.
Oh, thank you.
Individualizing a treatment. How can we, in a chronic pain patient, neuropathic pain patient, a CRPS patient, a combination of neuropathic and nociceptive, centrally sensitized, visualize the treatment? How can we just not say this is medications only, medicine only,
Yep.
or I can use more and jump elegantly? You put a lot of new stuff inside here, including Botox and including, what about other techniques?
Yep.
What about doing more than, you talked about Versatis, you talked about things. How can we jump from this to injection to others where we can continue to slide up and down? Many of these patients have problems and liver problems, and many of us,
So I think obviously that's why when I first started off with my talk, I said I'm focusing more on the medication side of things. But I think this is very, very important, the multimodal approach. So there's absolutely no reason why when you say do a lumbar sympathetic or a state ganglion block for CRPS, it can't be on to prove the effectiveness of the block. There's no reason why you can't do a cognitive and behavioral pain management program in addition to the block at the same time. Because the program plus do the block, it tends to be more effective. So I think it's important to put everything in place and say, okay, we're going to put it all together. And so while they're actually having the block, they're also on certain neuromodulating medications at that same time as well. Not just put or something like that and say, okay, I'm just going to give you, a particular interventional thing. Yeah, together. Yeah, so do the infusion and have them on medication at the same time. So there's no having them on a small dose of amitriptyline and a bit of pregabalin if that's the way you want to go, and do the infusion while they're on those small doses of medication. Yeah, but put it all together. So use it as a multimodal, don't isolation. So put it all together and you'll have more success with your patients.
Okay, that's it. Thank you.
Thanks, Dr. Agarwal. This was really the brainstorming session. And thanks the audience for taking this much interest. Now, I would like to request Dr. David Nagel to please come onto the dais and felicitate Dr. Agarwal, Dr. Arun Agarwal, with the keynote speech.
All right, folks, it looks like I have double duty today. I'm going to go ahead and introduce our next speaker. It's going to be Dr. Terry Lewis from the National Tsinghua University of Education in Taiwan. So without further ado, and she's going to go ahead and give her her bio there. Applause.
Yeah, I can do that. This is such an interesting meeting, and you're such an interesting group. I'm really pleased. I didn't know what to expect. So I'm going to take the few minutes and tell you briefly what I do. I'm the person who lives in the community who deals with your patients. I am a rehabilitation specialist. I have been in this business since 1972. I deal with mental health aspects. I train PTs, OTs. I train patients, physician education. I am the parent of a young man with a spine injury who has been dealing with arachnoiditis since he was 15 years of age. So that set me on a path that is a collision course with our current practices. And for the last 2.5 years, I had the privilege of interacting very closely with 360 families who were impacted by meningitis outbreak and contaminated drugs, and dealing with that across the U.S. So it's been an interesting process, and I consult with foreign schools and U.S. And I am doing duty right now in Taiwan, working with them as they work with their redesign of their healthcare, mental health care, and rehabilitation systems, teaching PTs, OT, and mental health practitioners in Taiwan right now at medical schools and at National Tsinghua University. So that's kind of me in a nutshell. So I want to talk about the relationship of pain management and patients, because it's fraught with difficulty these days. You all know it. We all know it. And I want to talk about how particularly in the U.S., what we do in the U.S. affects others around the world, because, you know, we believe we have the best healthcare system in the world, but we have to question the basis. So rehabilitation practice is really the canary in the coal mine. We see people before they interact with the medical system. We see people while they're interacting with the medical system. And then we see people for the balance of their lives once the medical system has decided that they can do more for them. And so we get a vantage point in rehabilitation that I think is an important vantage point, and it's something that we need to listen to, because there's a lot that happens. We look at something that I've come to respect as John Banja, who's an ethicist at Emory, whose work I've been following for a while. He's coined the term normalization of deviance. And that's an important term for us, because as we look at how our medical systems are working, we have to question whether we're hardwiring in some heuristics that may not be working very well for us, and we don't know whether they're working very well for us because we're not collecting the right data and asking the right questions. So doctors feel that together, and I'm really concerned as a patient trainer about where things don't work. I'm kind of a systems thinker, and I think that our dialogue is in trouble. So I want to raise that issue. Working alliance, I think, is a concept that's pretty in trouble right now. We need to be looking at that concept in terms of how we encompass all the factors that we bring to bear in treating people who have chronic pain. We're not doing that. And when we employ the heuristics of interventional pain as a one-size-fits-all, it's like going to the shoe store and getting everybody a pair of Converses. So what we talk about, and I'm delighted to hear people talking about dealing with a patient who's in front of them, in fact, it breaks down. And it's something that we have to talk about. So we all know the definition of chronic pain. We all know that people experience chronic pain differently. And they experience chronic pain differently because they're at different stages in their lives and experience and education and learning when the experience comes to visit them. Children don't experience chronic pain in the same way that teenagers experience it. And people who've lived long, productive lives don't experience chronic pain in the same way that the elderly do. But the models that we work from don't account for those differences. They are very important differences to outcomes. And so as on the patient side, the patient education side, I think it's really important for us to understand that people are living in a community, and that community experience has an awful lot to do with how successful our attempts are to treat them. I don't know, maybe I can learn to deal with these arrow keys. Heuristics are something that are pretty interesting. They're the things that we believe are even if they're not exactly true. And medicine is full of, as is rehabilitation and mental health practice. And it's the filter to sort and select the treatment protocol that we're going to utilize based upon the characteristics of the person who's in front of us. And that's pretty important for us. So we heard earlier about how people cure. And I want to talk about that a little bit because that's a really important part of our dialogue. The medical model is based on cure. I go to the doctor and I expect that I'm going to get a cure. All of the outcome measures in the medical model are based on cure. They're adherence and conformance approaches. We're measuring adherence and conformance in determining whether or not our patient outcomes can be interpreted. Okay? That really has very little to do with our intervention, because our intervention should be measured in whether or not what we do allows that person to operate in the community of their choice. So do what we do make it better? And we're not measuring it. And the cure has nothing to do with it. The bottom line is that in the field of pain management and chronic illness, the cure is an oxymoron. It's not there. It's not ever going to. So we're looking at coping instead. And for me, that has been kind of a big aha. Thousands and thousands of people that I see who cross my path. And as a parent dealing with this, I think it's a very important limitation of our thinking as we design our interventions. Are we measuring the right stuff? Are we asking the right questions? Patients are looking at quality of life issues. Their heuristic is different. The patient is looking at the medical model issues for the most part. So while the physician is looking at population statistics, patient characteristics, demographics, and therapeutic adherence, conformance to the care plan and the cure, the patient is looking at quality of life, beliefs, and information, their own self-efficacy in dealing with the problem that they've got in front of them, how they're communicating with the doctor that they're dealing with, and the power differential that exists. The patient is concerned about the patient. They could care less about population statistics. And so if our heuristic is looking at what the population and the medical clinical trials are telling us, that has nothing to do with the person in front of us. And so that's an important limitation of thinking. Multicultural aspects, I've never felt that as much as I have felt it being in Taiwan. but it is so critical in terms of how the patient receives support from their community, how much family support they have, what the expectation for them to operate in their community. All of that drives how they measure their outcome. And it has nothing to do with how we measure the medical outcome, which is still based on adherence, conformance, and cure. That's a really important issue for us. I expect that since this is such a national group, that some of you may be more sensitized to that than others. The patient goes to the doctor, they expect empathy, and that has to do with whether or not they're going to have satisfaction with their outcomes. Very different perspective on the problem. Very different expectations on the problem. So here's how we measure the cure and whether or not the patient has pain. And we all know that this model fails us terribly. It tells us nothing about how that patient functions. And if there is one thing that I see that we need to do better, is we need to be asking the patient what the chronic pain that they're dealing with on a daily basis, how it imposes limits on the expectations they have for living in their community. Can they go to the grocery store? Can they take their child to school? Can they go to the PTA meeting? Can they drive their kid to a birthday party? If chronic pain is limiting those things on a daily basis, that's how they're measuring them. Okay? That's a very important heuristic for us. And we overlook it when we look at this model, which tells us nothing about how people are functioning with or in spite of their chronic pain. Okay? Crazy world out there, particularly if you're in the United States, and so much of what the United States does bleeds over into other parts of the world. Patients are trapped in the DEA battle, and patients are sick of it. It has harmed them greatly. They go to the pharmacist, they can't get their prescriptions filled. They need to see their physician won't call them back. It's not 30 days on the calendar yet, so they can't get their questions answered. The whole business of being a legitimate pain patient who has to go to the doctor on a monthly basis and drive 300 miles to do it, round trip. For people the doctor. I started a year ago with this before the opioid transition to the new regulations, to find out what people understood about the projected changes that they would experience as users of opioids. And I know most injured people, they're going to be long-term, lifetime patients. Most people did not have an understanding of how these schedule changes would affect them. However, in the process, I've got about 5 responses on that first survey. We have people, response group from all over the States, who in some cases are driving 500 miles. One woman has to be loaded onto a gurney and get on an airplane and fly from the state of Maine to see her physician. Okay? That's terrible. And our system has driven people to this. The distribution of resources for management are dwindling rapidly. And the more restrictions that we are putting on the medical community, more our physicians are flocking to areas where they can be supported in other groups and other processes. So it's creating quite a problem. The second survey that I started about 3 weeks ago, to find out from this same group how in fact they had been by these changes. And so I'm going to be pulling the cohort out of this as it goes forward. And in many cases, patients have had to move because they've lost their physicians to change states, and because they've lost contact with people who know them. The minute they a practice, they are now treated automatically like a drug seeker. They don't have pharmacists who know them, and pharmacists who do know them and were treating them and filling their prescriptions for long term, they're gone. They've dumped them. They won't prescriptions anymore. So that's quite a problem. You all know that's going on. You're affected by it personally. It's something we need to be working with each other on. And you know, this current climate that we're working in should, we need to do better at reestablishing the science. This is a kind of a brief description pulled out of some of the survey results that we're dealing with right now. And of these two surveys we're looking at, 27% of the respondents report that their working relationships with their physician has just absolutely deteriorated. It's been a process. The physician's afraid to treat them, tolerate a conversation that goes in the direction of, hey, this is not working. And 21% at this point that they have to change their pharmacy because they can no longer get what they need from their pharmacy. Associated with the experience of dealing with different sectors of their support, from patients, pharmacists, medical, workman's comp, community, and DEA, FDA. These are the terms that have come through the comments. Patients have chronic they are referred to increasingly as addicts. The pharmacists will deal with them because they're drug seeking. The medical community is passing them around because they require many, many different approaches, and one size doesn't fit all. And we have to do something about that, because if we have a patient who requires many approaches, that doesn't mean they're drug seeking. It means we haven't found the right combination of stuff yet for them, okay? Malingering, workman's comp calls them malingering. Workman's comp has, you know, a lot of influence on what we do here. And you know, increasingly the media refers to them as people with aberrant behavior because they have chronic pain and they've been injured, okay? That's quite a problem for us. I have personally seen that develop in particularly children and teenagers with chronic pain. Who grow into this whole process of being labeled as aberrant because kids don't have pain. So particularly if you're a male, a teenager with chronic pain, and you require services, you're a drug-seeking teenager. That's quite a problem for us. So this whole concept of normalizing deviance is becoming quite embedded as a heuristic into our approaches and the rational allocation of resources. And it guides so much of what we do and what we do in terms of insurance companies, workman's comp, and so forth. Okay? But this is a definition of it. It works pretty well, and I didn't ever really start thinking about it until I began to deal with the fungal meningitis outbreak, and we're going to talk about that later. But intentional care standards are often practiced or conducted by the entire group, insurance companies, pharmacy groups, physician groups. What begins as a deviation from a standard of operating rules becomes, with enough repetitions, normalized practice patterns. So George earlier made reference to this move from integrated care to interventional approaches. And we don't know a lot about what's happening there. But at this juncture, personnel no longer regard these acts as untoward, but rather as routine, rational, and entirely acceptable because everybody's doing it. These latent errors become entrenched in the system's operating architecture and they dramatically enhance the vulnerability when a future active error is committed. This is a real problem for us in pain management right now. Okay? Real problem, and we're not measuring it. We're indication of its effects, but we're not doing the research on it. So, to prepare for this was to go through the process of looking at, the patient has this belief about something called do no harm when they go for pain management support and treatment and any kind of medical intervention. The physician is operating from a position of do no harm. That's their heuristic. It's hardwired in. And there's something in that. I looked at all of the medical oaths and so forth to look for where that comes from. I couldn't find it anywhere. And in fact, it's not there. So then I looked at what is there, and I found this interesting article in PubMed about overtreatment and therapeutic nihilism, because overtreatment is another heuristic in the public landscape of conversation. The belief that a lot of medical harm is a responsive practice of medicine. Everybody in the room is an issue, right? So we either overtreat or we don't treat enough, and somewhere we don't know what that balance is. And that balance is affected by not only our personal approaches to medicine, but those of our partners and what people are going to get paid for and so forth. So this is an issue for us. It's a public conversation we have, and I'm not here to tell you that I know what the answer is, but I see the results. And I see it on the patient side. And they don't get to pick where this falls out for them. If we're looking at population metrics versus person metrics, we're looking at the medical model here. We're looking at population, person, symptoms, results, outcomes, and impact. Impact is where we need to be. The medical model is very focused on results. And results are measures that are based on activity-based indicators. I'm an evaluator. I do a lot of program evaluation. And so one of the things that I've gotten really interested in is how we measure our public outcomes and our public impact, because we have to be interested. That has a lot to do with our resources and how we make decisions. So the medical model is a piece of what happens when people live in the community. It is a group of activities for which there are measures associated with it. But if we fall short when we look at just the results of our activities, because we can't the impact of the decisions that we make. Impact is a community measure. It's based on groups of activities result in outcomes, and then those outcomes as a group fall into impact measures. So with all of this noise in the news about how resources are allocated and hospitals shrinking and physicians, the impact of our medical decisions on who live in the community is really the only true measure of our effectiveness. So we really need to be what that means for us. And then we've got this whole issue of the tyranny of perfection. We're supposed to, everybody in this room is supposed to be an expert on whatever it is comes in the door. You're supposed to know that. Especially since you don't get to pick your patients, and patients don't get to pick their doctors in the current climate. Okay? So it's not reasonable to think that you're perfection and that you can make a decision for everything that but the tyranny of perfection is a problem for us because it's burning out. It's burning out physicians at a high rate. The pain industry are very vulnerable, like their patients are, to suicide. Who don't get properly served are vulnerable to suicidal ideation because they give up. And they don't have the energy and the resources and support to go through this process of multiple regimens and getting them to. They don't have the personal resources in their own homes to do that. Okay, they burn the people out around, and the U.S. are committing suicide. I'm from Tennessee, and last week, a long-term family physician served many people in rural community outside of Nashville, committed suicide, 63 years of age. A lot of patients lost as a result of that. Lost. Just had enough. So I deal with rehabilitation, and I like that model because it's very community focused, and it spreads our responsibility around. It says that people function in a system, and medical people function in that system, as do PT and OTs and schools and churches and stores, and everybody has a stake in the outcome. Now, I'm a person who's put together services in rural areas for many years, and I know from personal experience that the effect of what I do is measured not in terms of my own behavior, but in terms of whether I can create access for the people that I am working with in their own community. So as somebody doing rehabilitation, a measure of my success in terms of my own supports and education is whether that person can go open a bank account with a significant disability, whether they're treated as a member of their community, and resources can be pulled together for, and you know how hard it is to get a bank account these days. I mean, it's really difficult if you're on disability, but the day you can go open a bank account means that you are functioning in your community. You can still have a disability, you can still have chronic pain, you can still have all of these things going on, but you're optimum, so we need to be thinking about what that means. We've got these competing ideas of medical model versus community rehabilitation model, adherence, conformance, and cure versus quality of life and participation in the community. Patient versus person, and results versus impact, okay? I want to come back to this notion that cure and chronicity are oxymorons, and that it's sort of that heuristic that's not working for us. Medical model, community model of care. Medical model, patient versus person. Disease symptoms versus wellness. Adherence versus meaningfulness. Cure versus stigma and exclusion. In the medical model, this is kind of an aha that I've been thinking about for the last week. Oh, I'm sorry about that. If you could just turn that off. That's my son with chronic pain. I just got into the U.S., so he's like calling me, okay? I'm sorry about that. Treatment versus exclusion and isolation, and discharge versus handicap, okay? There's not a day that goes by that I'm personally reminded, and you're not personally reminded too, that the medical model cannot cure somebody with chronic pain. It won't happen, but that's our measure of outcome. And the only thing that measure of outcome can do for us is to fail not only the physician, but it fails the okay? It sets us up with the wrong measure and the wrong set of expectations. We have, take this oath, may I enjoy life in art, respected while I live, and remembered with affection thereafter. There's a real polarized atmosphere in the U.S. between pain patients right now and the pain treating community. You didn't create it. You're victims of it. But it bleeds into other countries because we have the best healthcare system in the world, okay? Which is not true, but we claim to. And what plays in the U.S. rolls out around the world. I've seen that personally in the last couple of years. So we need to keep this dialogue very elevated and find a way to deal with that in our public discourse, and maybe a meeting like this is one of the best ways to do it. This is a cohort study that I pulled about polypharmacy. The opioid wars tell us that if you have chronic pain, that you're being messaged as an addict, that's quite a problem. And Aaron about the use of other medications and so forth. What I see, people that I deal with, they are victims of polypharmacy. And that polypharmacy is often a one-size-fits-all model. And there's no attempt to measure anything more than adherence and conformity for that notion of outcome, but that's not being communicated to the patient. So the patient goes to the doctor faithfully every 30 days, and they are adhering and they are conforming and they're peeing in the cup and their pain isn't going away. And nobody's asking them if it's getting better or what will make it better. Okay? And their 5 minutes in the doctor's office isn't getting the conversation held. So we've talked about that. We know this is going on. I want to acknowledge what a burden this places on the profession. I have friends in the profession who are pain treating physicians who I respect greatly because they work with the hardest people to serve, and they've got a gun to their head. And it's a tough climate for them right now. Patients are responding by engaging in petition-generating activities because it's the only way they feel like they've got any power and control, even though it's not likely to yield much of an outcome. There's all drug war. We're all victims of that. We are equal of that right now. Rand Paul is a political campaign issue. Suddenly, back pain, chronic pain means that you're an addict, you're lazy, gaming the system. And the evidence for that just there, but the public messaging puts quite a burden on all of us when that happens. And we're silent on this subject, not speaking out about it. I went to look at do no harm. I don't know what do no harm means right now. And I don't think that anybody in this room knows what that means. Not represented in any of these oaths, and I do think that we're really getting... the chronic pain concerns right now are that what I see, and I've checked these statistics pretty regularly, people of working age who contribute regularly to our economy are being pulled out by injury. Okay? That's harmful to our economy and it's not sustainable. The majority of people of working age are the ones who are applying for disability. Children are increasing in numbers of chronic pain. And this doesn't favor one group over another. We do see that there are people with different characteristics who survive the system in better shape than others. So we have a vested interest in talking to each other about these issues. This is a forum to do it because there's lots of people in the room with a lot of different perspectives. I think it's really important that we not talk around each other, but that we talk to each other. So I'm here representing lots of patients, lots of patient groups. And as a professional, I'm very interested in this dialogue. So thank you. Let's begin the conversation.
Ladies and gentlemen, at this time, we're going to take one, maybe two questions at the most. You want to answer a question, ma'am? Well, go ahead, if you would. We're going to take one question, and then we got coffee break.
Yeah.
Good afternoon. That was an excellent presentation, and it covered a lot of the the problems that we as physicians worker live with in this pressure cooker.
Elephant in the room.
That's right. You know, I've written a number of different pieces about the issue of the insurance companies, the overburdensome regulations. The solutions. I mean, where do we begin to find answers to the issues of 400 doctors committing suicide? I mean, why isn't that more public? Why don't people out there say this is an epidemic?
In my work life, because this is what I do, I've gotten real interested in systems work and heuristics, and I think it's a cultural thing. I think personally that it's a lot about power, control, and community, and that we are conditioned to operate within our respective stovepipes, and that increasingly that's not working for us. When we're operating within our stovepipes, we can't see over the wall. We're not interacting with people who might challenge our assumptions. So I think it's really important to not stay silent. I think it's really important. This is a great opportunity for patients and physicians to begin to get in the same conversation. And I think that has to happen in order to manage these issues. Because the people who are making these decisions are not informed. They're not responding to the things that have the same meaning that we are, and we're not moving the field at all. George.
I can just throw a plug, because, I mean, there is kind of a ban. I think, oh, sorry. There's an organization in the United States, it's called the Pain Action Alliance, to implement a national.
Yeah,
And
I
they're
wrote a
very-
letter for that.
And they're very much involved in, you know, the Institute of Medicine released a report in 2011, a blueprint for changing the way pain is perceived and managed. And there's a national pain strategy that the initial draft is out right now. And there's a lot of forward movement, and you can be involved with that. It's a bandwagon to change, do everything you're just saying. With that said, today's set Monday, right? Yesterday morning at the American Medical Association, the New York State Medical Society presented a position that they wanted the pain as the fifth vital sign to be removed, taken. It was, I got a frantic letter to contact all my representatives to make sure that that doesn't happen, but their reason for doing it, they're talking about, New York State is so focused on prescription drug abuse and opiate abuse, that they felt that listing pain as the fifth vital sign was akin to saying we can cure pain, and it was leading to excess prescribing, and they want it gone. And it's a very myopic position. Try to get opiates in New York State these days. It's really hard.
I think this is y'all don't know me. I'm a reasonable person. I've been doing this a long time. I think this is a manufactured problem. I think it is marketing, it is merchandising, it's creating a problem that does not exist in the way we believe it exists. And the patients that I deal with, and I'm talking thousands of severely injured patients over the years that I know, that I've come to know pretty well, their lives don't reflect that reality. So I just think we shouldn't be silent. I wrote a letter for the National I decision personally as a professional to spend the rest of my life dealing with the issue of silence. I teach patients how not to be silent. And we all have to change this conversation. We have to change this conversation. And we got to work together to do it.
I agree with you.
Yeah.
Doctors for too long have been too silent on too many of these issues. And,
Yeah.
You know, the narcotic one, I think, you know, for political purposes, it's being hijacked.
It's absolutely being hijacked. I was just, Kentucky's here. This gentleman is from Kentucky, and I've lived and worked in Tennessee for 30 years now. So, you know, I know rural. I grew up in Montana. I get it, okay? I have a son with chronic pain, and I have with the same back. I know what that's like. So we're having to cut this off. This is a great conversation. I hope we can continue to have it.
Yes. I'm here to present a paper entitled Efficacy of Different Physical Interventions in Rehabilitation of Medial Knee. Osteoarthritis is one of the most common cause of disability in the world, and if epidemiological studies, then 43 million of persons are affected with osteoarthritis only in US, and 15% of world population is affected with osteoarthritis. The cause is usually degeneration or process, but that is not the only cause. Nowadays, they say that it is the disproportion between the stress and the stability of the individual joint components, due to which the healthy joint components are being replaced with the inferior tissue. And we can see on this next slide that the first one is showing the healthy cartilaginous tissue. The cartilaginous is not visible. Picture, you can see that this is stage 1 osteoarthritis, in which the cartilaginous fibers have become visible, and in the second stage, that is stage 2, all these fibers have been broken down and they have made the nest-like structures. And in the next, that is stage 3 osteoarthritis, the most of the articular worn away and the underlying bone is exposed. And in the last stage, the stage 4, the advanced stage of the osteoarthritis, the whole of the articular cartilage has been destroyed and the bone is exposed, the subchondral bone, and which is now taking more load. This is about the knee joint. This is the healthy knee joint, because my study is on knee joint. So this is the healthy knee joint where there is smooth articular cartilage on the patellofemoral joint and in the middle compartment as well as in the lateral compartment. But in the early stage, there is roughening of this articular cartilage in the medial compartment as well as in the patellofemoral compartment. But still, the lateral compartment is being spared because this is the early. And in the advanced stage of osteoarthritis, you can see that almost all the articular cartilage has been worn away, and there is sclerosis, there is inflammation of the synovial membrane and the capsule. Synovial membrane inflammation is just actually not the primary change of the osteoarthritis, but it occurs as the secondary change, actually in the advanced case. So these are the changes that occur, or the pathological changes that occur in osteoarthritis. What clinically, naturally, the joint pain is the first symptom, and then there is stiffness and swelling, which leads to the muscle weakness because activity level is reduced, and this muscle weakness results into the further impaired physical function. That way the vicious circle goes on, and the patient has more and more problem. But the current knowledge says that it is not only the clinical symptoms, it is the role of biomechanics, which should be in the case of development of osteoarthritis, especially in medial knee osteoarthritis. Why medial knee? As such, all the weight-bearing joints are affected, but knee joint is more affected. Why? Because it incorporates the sliding, rotating, and the rolling movements, which are the accessory movements, the flexion and extension of the knee joint. These accessory movements are also involved in the, and therefore the medial compartment is more affected. Another reason is that the 60% of the medial lateral load is beared by the medial compartment, and that's why the medial compartment is more affected or affected than the lateral compartment, and therefore our study is in the medial compartment osteoarthritis. And another thing is that it is resulted into the varus angulation deformity, which further causes more load on the medial compartment. So the study says that every 1 unit increase adduction moment or in the varus compartment, there is 6.54 risk of the middle compartment of the osteoarthritis knee. And in this line of thought, we designed our study, and there were 3 interventional approaches. Like the objective of study was to compare the efficacy of the concurrent application of footwear alterations and knee bracing with that of the footwear alteration alone. And the third group was the convinced, in which we had the convinced tell you about the components of those treatment program. This was the procedure. Research design was the randomized controlled intervention trial, and it was carried out in the research lab, Department of Physiotherapy, Punjab University, Patiala, and the different centers were there to have the patients of osteoarthritis. The was taken prior to from the Institutional Ethical Committee, Punjab University, Patiala. Informed consent was taken from the patients. These were the area from the patients from where the patients were taken, and this is the selection both male in the age group of 40 to 70 years. Patients who had the knee pain for a period of minimum 6 months were taken, and who were only in the advanced stage. Those were taken. Medial joint arthritis patients, and these patients were with the surgery of the lower limb or with other neurological disorders. Independent variables were the footwear alteration, knee brace, and the conservative treatment. These were the dependent variables, that is the clinical outcomes, pain and functional status. Pain was on the VAS score, and the functional status was measured by WOMIC, radiographic changes, static alignment, factors, gait parameters, and the plantar pressure distribution. These were the tools. For weight, body load was used for the measurement of height. VAS was used for the measurement of pain. No pain means 0 and 10 was the worst case. Box was used for the measurement of the joint space width. Joint space width was measured by the computerized measurement method, and these were the instruments for the kinesiological factors. This was the sit and reach that was used for measuring the hamstring flexibility. This was the moist high heat therapy pack that all patients in all the 3 first given the moist heat therapy for 15 minutes to have the muscles relaxed, and interferential therapy was given in all the groups. That was to reduce the pain. This was the medium frequency current given to the patient in the range of 2000 to 4000 hertz, and then static cycle was used. This was the Harris-Met for measurement of the plantar pressure distribution. That is, the patient's foot impression was taken in the standing position with 20 to 30 degree flexion, knee flexion, and after that, that impression was scanned, and then with the help of the Podia scans, it was color coded, and then we were able to measure the plantar pressure in terms of Newton per centimeter square. This was the lateral wedge which was given in one of the experimental groups. That lateral wedge was given in the 2. This was the knee brace, the valgus brace, which was given in the another experimental group. So outcome measures were pain, as we have seen, pain measured on VAS, functional status measured on WOMIC index. This was the radiographic changes measured, joint space weight was measured, computerized. This was the static alignment. In the first figure, the Q angle is being measured, and then with the X-rays, genu varum was measured. This is how the tibial torsion was measured. And the knee range of motion in the first figure, and in the next two, the isometric strength of quadriceps and the hamstring muscles was measured. This is how we use the sit and reach test box. Hamstring flexibility and quadriceps leg was measured, that how much difference is there in the full knee patient's actual extension of knee. This was the gait parameters, that we took the ink impression of the foot on the distance, and we measured the step length, we measured the stride length, cadence, and the velocity of all the patients. Those were the gait parameters this way, and the plantar pressure distribution that was measured on with the Harris-Met, as I showed you earlier. This was the scanned foot impressions on the Harris-Met. So there were 3 interventions. Was given the conventional physiotherapy, in which we had the isometric quadriceps exercises, strengthening program, knee mobilization, and group, that was the experimental group 1, which was given foot, and along with the conventional physiotherapy. In the third group, we had footwear alteration, that is the lateral wedge, bracing, valgus brace, and the conventional physiotherapy. Thus, we had 3 groups. So data was analyzed with statistical. And this is the first table, which shows the demographic characteristics of all the patients in all the 3 interventional groups. And this shows the efficacy of all the physical interventions in the medial knee osteoarthritis within the group, that how much was the difference in before treatment and after treatment. And as we can see, in the control group, that is in the conventional physiotherapy group, we had improvement in pain, improvement in functional status, but we had difference in the radiographic changes, but that was decrease in the joint space width. That means the osteoarthritis was developed further. That was the negative thing. And then in static alignment, we had the changes in Q angle, Then Genuvarum, but Genuvarum was not improved in control group, whereas it was improved in experimental group 1 and 2. Similarly, radiographic changes were improved, that is joint space which was increased in experimental group 1 and 2. That means the development of osteoarthritis knee was arrested. That was a very good sign, really the encouraging results. And in kinesiological factors, we had the increase in quadriceps strength in both the experimental groups, but not in the, of course, hamstring strength was increased even in the control group. Rather, hamstring strength, knee range of motion was increased in all the 3 intervention groups. Gait parameters, as far gait parameters are concerned, again, there was no much improvement in the gait parameters in control group, but we had the very good improvement in experimental group 1 and 2. Similarly with the distribution also. This was to compare the improvement between the 3 groups, that we had the improvement in pain and functional scores in all 3 interventional groups. But this magnitude of improvement was more in experimental groups rather than the conventional group. So, in discussion, the first of all, static lower limb alignment and the varus alignment. So, we had improvement in the varus alignment was reduced in the experimental groups, but not in conventional group. Naturally, biomechanical alterations were there by using knee brace and by using the lateral wedge. But in conventional physiotherapy, we had the exercises, but there was no biomechanical alterations. So, this may be because of the valgus knee bracing use that external valgus movement was reduced. And Q angle was also improved in both the experimental groups. Tibial torsion was not much affected. Rather, tibial torsion was in the normal range even prior to the treatment. So I think we should have the further studies in respect to the tibial torsions. So we didn't got much results, encouraging results in respect to the tibial torsion. Yes, radiographic changes, as I said, there was improvement, there was an increase in the joint space width in both groups. And in plantar pressure distribution, again, very much encouraging results. That before treatment, we noticed one thing, that was lateralization of the weight bearing. That people, all the patients in all the groups, they had more weight bearing on the lateral side of the foot rather than the medial side. And this is the preponderance of all the osteoarthritic patients. What we got as a result, that there was medial shift of plantar pressure distribution from lateral to medial. And this is what actually needed for the osteoarthritis to arrest the development, further development of osteoarthritis. And we got it. As far as kinesiological factors are concerned, we had improvement in the quadriceps leg, that quadriceps leg was reduced. We had increase in the strength and flexibility. And gait parameters were also improved. So, in the present study, like this may be the experimental study where we investigated the concurrent effect of lateral wedge and knee brace. We have the prior studies who have seen the report or who have given the reports regarding the only lateral wedge use or only knee brace use, but we had the concurrent use of the lateral wedge and knee brace along with the conventional physiotherapy. And the possible explanation for the results could be that the patients with knee OA may receive the greater load reduction in the medial compartment, the valgus knee and the lateral wedge, and the results of the patient study may help clinicians to find a novel way of concurrent use of the lateral wedge and valgus brace along with the conventional physiotherapy to help the patients with early medial OA in future. Thank you.
All right, we do have time for a couple of questions. She has a couple of more minutes left. Does anybody have a question for her? No? Okay.
Yes.
All right. A very important lecture, and at least in the U.S., we're faced with a significant patient population on the hundreds of thousands every year that go for total knee replacement. So if we can make the lateral wedge and the knee bracing part of our armamentarium, along with some other ways we dampen the pain from the geniculate nerves, I think we could probably offset a significant amount of these total knees, and I think that's where this is most important.
Yes, yes. We have 2 approaches for the treatment. another is not surgical. So in surgery, nowadays they go for the replacement even in the younger age. And that is very discouraging. Even in the young patient, for young patients, they recommend the knee replacement. And if you are using this, if you are arresting the disease in the earlier stage, then we can prevent the replacement surgery. Yeah.
No, I think it's a very important.
Okay, right.
All right, I guess we'll move on then. All right.
Yeah, thank you.
Okay, yeah. Yeah, good morning, and thank you for the opportunity to present some results here of a potentially novel therapeutic with a somewhat novel mechanism of action. I'm actually, as you can hear from my accent, and after my neurology training, decided to join pharmaceutical industry and dedicate my career to research and in trying to help develop new therapeutics. And as such, I've been involved in some of the registration trials for pregabalin, which has been mentioned a number of times. And of course, we know that not all patients respond to treatments, and treatments have side effects. So the search continues. And I'm currently consulting with a company in the UK, which is called Convergence, recently acquired by Biogen, and this more selective type of sodium channel blocker. And what you see here, and I realize that not all of you are pharmacologists, but so the concept is here that the this medication is more selective for a certain subtype of sodium channels, which is the 1.7. And the 1.7 has been implicated in genetic pain conditions. And the one condition is actually when you don't have this channel, you don't have the capability of feeling pain. And that sounds great, but these patients are developing osteoarthritis because they just overuse this, and they get burned because they don't feel the pain. But there are also genetic mutations that have a hyperfunctional channel, and these patients develop very often a condition which is called erythromelalgia. It's a very rare condition, 3,000 to 5,000 people worldwide, and not all of them have been characterized genetically. It have been evaluated in the lab by Dr. Steve Waxman. This is resonating too much. And really showing that there is a hyperfunctionality of this 1.7 in erythromelalgia. And so the fact that this drug seems to be more sensitive, which means there is 50% inhibition of the 1.7 channel at 1 microgram, and higher concentrations are needed, higher doses are needed to have the similar inhibition of the other subtypes. So there is a functional selectivity here. And what happens, what's interesting with this compound as well, there is a use-dependent block, which means, so if you repeatedly fire a neuron, normally there will be a little bit of adaptation, but with this drug on board, the action potentials will actually decrease. So what it does, it reduces firing action potentials. It probably does so by keeping sodium channels in an inactivated state for a longer time. And if you compare to carbamazepine, it has a little bit of use dependency, but not that much. Probably, so carbamazepine also is not selective for the 1.7, and the lack of use dependency probably explains that you need to get to doses that impair normal function to make it actually have an effect on pain or on epilepsy for that. So this drug, the steps of clinical development, take a long time, and it goes from small phase 1 studies with single doses in an ascending dose sequence, followed by multiple dose studies. And in this situation, there was a dedicated study for blood pressure monitoring, provided very good cardiac safety results in terms of blood pressure and ECGs. And here's the pharmacokinetics. So you see how many doses have to be tested in order to get to that seemed to be the maximal tolerated dose. And this is linear, so if you double the dose, the concentrations double. And it has a half-life of about 12 hours, so it should be suitable for 2 or 3 times daily dosing. So Convergence, and that was before I even was working with the company, they conducted a small phase 2 study in subjects with trigeminal neuralgia. And these studies are quite difficult to conduct because it's not very common. And for the purpose of clinical trials, the company really has tried to select patients that were evaluated by pain specialists to really have trigeminal neuralgia and not atypical facial pain conditions. So it was a highly patient group. And it was a special design, which is work with opioids mainly. It's a randomized withdrawal design, where in an open label phase, first everybody gets the study medication, and then after 3 weeks, only people responded based on certain criteria, which was in this case reduction, got randomized to either staying on the study medication or going back to a placebo. And then what is measured is the maintenance of effect, hopefully, versus people losing their response. The numbers are interesting as well. So a large number of patients actually was screened across multiple countries in Europe, 125. Only 67 actually met the criteria. And that means that many people actually get labeled as trigeminal neuralgia, but some of them may have some more atypical characteristics that wouldn't make them suitable for this particular study. And so 44 actually stayed out, and so only 31 actually met the randomization criteria of actually being a responder, and were then randomized to 15 on the study drug and 14 to placebo. So the ending results, the ending numbers are relatively small because of all these difficulties. So here are the responder criteria based on the number of the paroxysms and the severity of the paroxysms. And this was measured using a patient diary. In this case, it was still a paper pencil diary. For future studies, we would like to switch to an electronic diary, which is more user-friendly. And so after the randomization, the first endpoint was how many patients actually failed treatment. So the idea was that if you stay on the study medication, randomized in a double-blind fashion, you would keep your effect, and if you would be on placebo, at some point your severity or number of the paroxysms would increase, and you would meet at some point these treatment failure criteria. And here you see the actual table, and I'm showing the table because it's quite interesting why patients actually failed on placebo or on active. Frequency increased on placebo, so that's after the to double blind in 5 people here versus one study.
given in case of first group. This type of treatment was given. Then isometrics for lateral flexors and isometrics for rotators was given. Posture workstation, the most important slide for computer users in these days. We are using the computers, laptops, different mobiles for long duration without thinking about its side effects. This is the correct posture of the body and the computer. Right posture and wrong posture. Then in case of finger, when we are using keyboards, the right position of the finger is like this way and wrong posture is this. Work desk. In these slides, I can conclude that the furniture in case of computer should be used adjustable. According to your height, you can adjust the so that you can easily operate the computer with your fingers and body part, different body parts. Footrest, monitor. Branded monitor should be used. While you are working on the computer, you should rotate your head in different directions so that blinking is compulsory during the use of computer. Due to this reason, when continuously we using computer, eyesight is most affected. There is a lot of debate about the harmful effects of electromagnetic and electrostatic fields around the monitor. Precautions: keep the monitor at a proper distance. Maintain a distance of 3 feet from the back of any monitor. Keep the screen clean. Keyboard as thin as free to move, giving a distinct feel when pressed. Ambience: brightly lit room, light points on the sides of the. Then temperature in between 18 to 22 degrees Celsius. Humidity factor should be about 50%. Noise level. Work organization: no burden of work, no electronic supervision without the worker's knowledge. A few minutes break hour. Group B, muscle energy technique used in case of second group, that is the conventional treatment. Muscle energy technique and conventional treatment is given like this way. Then in group C, microwave diathermy used. Results. In this slide, we can see that while giving these three techniques are significant, pain and disability is reduced. The observations of the study in context to decrease in pain and disability after the interventions could be attributed to component interventional group. The superficial heat first intervention was attributed to reduce pain because application of hot pack reduces the sympathetic palmar swearing response. Muscle energy used in the second and third intervention known as analgesic effect. The current study of microwave diathermy in the third intervention had any additional benefits on pain reduction similar to our this in their effect of post isometric relaxation and isometric exercises in neck pain. The observations of the current study suggesting no additional effect of microwave diathermy added to muscle energy technique and conventional interventions on reducing are supposed by a study Ortega which stated that microwave diathermy does not provide additional benefit to a treatment regimen of chronic neck pain that already involves other treatment approaches. Conclusion: The study elicited that there was a significant effect of computer uses on neck pain, although increasing hours per week of computer uses seemingly positive relation with neck disability. Years of computer uses did not seem to have a substantial effect on neck disability or neck pain. With reference to interventional approaches, it is concluded that microbiometry and muscle energy technique, when added to the conventional physiotherapy program, may enhance the effectiveness of the protocol in the management of neck pain and disability among computer users. Modern machines can perform flawlessly for hours on end. Unfortunately, the operators behind them are only human. Thank you. I want to show the next slides only. This is the exercise program with the help of which computer users can take a help to reduce their neck, back, and other pain.
Yes, yeah, we got.
That was an excellent presentation. Can I ask you, these measures that you've talked about with regards to making more ergonomically friendly environments, do these have the support of the local governments, or are these just private companies deciding that this is what they're getting? I mean, has it gotten up to that level where the governments are saying this needs to be implemented on a wider scale? Because IT. Yeah.
Yes. I request Dr. Narinder to answer this query.
Yes. Very much right. We can recommend some of the suggestions based on this study and the different organizations, particularly MNCs institutes, where the people are very much, they are getting the jobs. Recommend. We'll try to do that. Yes. Your suggestion is very valuable. Yeah, thank you.
Okay, any other further questions? Okay.
I wonder, out of the if neck tractions, have you looked at that?
Again, where is this side?
I'll give the answer. He is actually from the computer field, and this study was the interdisciplinary study. The physiotherapy department and the computer department both were involved. So I am from the department of physiotherapy, so I'll give you the answer. Yes, you asked about the traction. Traction could be effective, but in this particular study, we did not include that part. That was not the component of our treatment protocol. But definitely, traction can be helpful. So we give technique, that was a stretching exercise, because in traction also we give the restriction, but that works mainly on the cervical spine, on the vertebrae of the cervical spine. This MET works on the muscles, because in computer users it is the muscle which are affected and not the cervical spine. That is because of age or other factors, but in particular computer professionals, it is the muscle which is affected, because the muscles are remaining in a particular position for the and therefore more effective. That was the reason. Any other question?
All right, so I'd like to invite up Hal Blattman.
It was nice to see a totally non-drug intervention.
Okay.
It was a non
nerves go out in between the fascia pieces of the muscle, and if the fascia pinches on that nerve, you have nerve-related pain. Fascia covers the brain, the omentum. Every nerve and every blood vessel that goes through the body is covered with fascia. The ligament structures that hold our body together are also part of fascia. And sometimes fascia is very, very tense and very, very tight. And you can't pull this fascia apart no matter how hard you tug at it. But if you pull from the sides, it will let go. So this fascia is ubiquitous. It's likely to be discarded during surgery, cleaned off in anatomy dissections so you can see something. It's one of the most underappreciated tissues in the body, and it is more important in more ways than classically taught. And with regard to personal injury, it is also termed soft tissue. It's historically difficult to assess or prove damage. It's historically not considered significant in contributing to disability. And many times, the fascia injury is the most significant injury leading to chronic pain that we have. The fascia forms a biological container and a connector for every organ and muscle. It ensheaths all bones. It is all one net with no separation from head to toe. And every cell responds and is hooked into the tensional environment of the fascia in our body. And this is a video showing us the posterior or superficial backline of human fascia. This is courtesy of David Lasandek and Tom Myers from Anatomy Trains. And just take a look at this, showing you that you are one piece. This is the bottom of your foot. This is your heel. This is the heel cord leading up to the gastroc muscle. You'll see when we get up there that the gastroc and the hamstrings are one piece of tissue. You can't pull them apart. You can't separate them. And then you can see that in this specimen, the hamstring muscles are attached, which means they get used together. If they are more separated, they can be used independently, giving the person different athletic abilities. This is the fascia over the sacrum, and then left up over the lumbar spine, and then the multifidus going up the mid-back. And up here on the left is the neck, and this yellow piece is the galea that goes over the top of the head all the way to the eyebrows. So what you have just seen is an anatomical dissection called a fascia-sparing dissection, showing you that we are one piece of tissue from the ball of your foot to your eyebrows. And in a similar fashion, there are deep and shallow lines of fascia up the back, deep and shallow lines up the front, deep and shallow lines up the sides, and spiral lines up the middle. And all of them connect. We have terminology differences and changes. We call them superficial and deep fascia, and epimysium and perimysium and endomysium, and that's all about whether the fascia is over the whole muscle or whether it's just over a muscle sector or an individual cell. And the fascia is made from an extracellular matrix with strong, pliable weaves of fibers. There are 12 types of collagen, elastin, reticulum, a glue that holds them together with colloidal gels and fibronectin and hyaluronic acid and, of course, water. And when you look at it on an electron micrograph, these strings are very, very tight in a similar direction. These are individual fibers of collagen removed from a human knee. We have body work in this country, and we name it many, many things. We name it massage and Rolfing and chiropractic and osteopathic and various sundry techniques. This is talking about the discussion that when the fibroblasts within a muscle are, they secrete the inflammatory mediators that start the healing process. When you tear the ligaments in your ankle and make an ankle sprain, the fibroblasts that make up your ankle ligaments set off and release the inflammatory mediators that make you swell, make you hurt for 4 weeks, and then grow you new fibroblasts and make you heal. 90 seconds of osteopathic stretch and compression will undo the inflammatory changes produced by injured fibroblasts when they're injured by 8 hours of strain from repetitive motion. So when you do body work of osteopathic manipulation or whatever you want to call it, you are changing at the biological level of the release of inflammatory mediators from the injured tissue. That's the level of change you're producing. If you make tendons in a genetic lab, myofascial release will increase the tendon weight. A longer duration will change growth colony and stimulating factors. Increased strain magnitude will create cytokine reaction. And what this shows us is that variations in body work and variations in manual therapies may differentially affect physiologic responses in that person, which will give us some understanding of why is your body work different than your body work, and why do people like to go to you for treatment instead of you for treatment, and even these subtle things that aren't taught in school but are a person's individual talent make big differences in their therapeutic results, and there's a real physical reason for it. Diverging just a little tiny bit. This slide showing that inflammatory mediators are made by injured fibroblasts. That's a local reaction, and that reaction happens in fibroblastic injury whether you cut them, whether you tear them apart like an ankle sprain, whether you beat them with a hammer, whether you burn them with acid or burn them with fire. They make the same inflammatory chemicals. The body has the same healing response wherever it is. In distinction to that, the fibroblast creates the same inflammatory chemicals when exposed to the foods on the do not eat list I mentioned before lunch. Only in that case, it's not localized, it's global throughout the body. And it's not that the reaction from the food caused an injury that is new, although it does. It's more that it made the injuries that have been there for a long time light up like a Christmas tree. And they will light up like that Christmas tree for the same 4 weeks as they light up when you sprain your ankle. So, moving along. The deep fascia of the limbs has different structure and different function. For example, the anterior region of the arm, if you touch your arm skin, it moves quite a bit. The dorsal skin moves a lot more. Those fascia parts have different construction for different reasons. The fascia of the leg is much tighter, and so stronger layers of fascia transmit tension at a distance, connecting the body for coordination. So how your fascia is constructed is largely has an impact on how you use your body. For example, the person with Ehlers-Danlos syndrome, you've got a tibia and you've got an ankle mortise, and so their ligaments are so loose they go over about this far before they even know they've moved. Where on the other hand, an athlete that plays professional soccer and he moves a fraction of what you would even move, and his brain already knows he moved. So as we're wired by our fascia and the interaction of the fascia tension with our nervous system, we have different physical capacities as individuals. These 3 layers of fascia merge at well-defined points, and that merging guarantees coordination of the upper part of the body with the lower body. There's a coupling between the gluteus maximus and the contralateral latissimus dorsi by the posterior layer of thoracolumbar fascia. The gluteus maximus inserts into the iliotibial band, the fascia lata, and the lateral intramuscular septum. It's not that the lower spine nerves create the sciatica pain that goes down the leg. It's the fascia injury in the buttocks that transmits that pain down to the foot. Not only this, but fascia contracts. Muscle contracts, we know that really well because we can say, hand, please go pick up a cup of coffee. Fascia also has muscle fibers in it. Increase in fascia stiffness will improve proprioception in the athlete or in the Ehlers-Danlos person. It will increase muscular activation and coordination. But there are connective tissue cells with muscle properties with alpha-smooth muscle actin, and they are fibroblasts, chondrocytes, and osteoblasts. Osteoblasts have the ability to contract and pull a fracture back together. It is thought to help with wound repair. There are myofibroblasts in fascia. And when fascia contracts, it alters the mechanics of the body. The cells of fascia can change their function. Individual structures are just artificial labels for areas within the singular fascia web. And the clearest example is there's no such thing as a medial collateral ligament of a knee. There's no such thing as a lateral collateral ligament of a knee. Those are artificially described structures by an artificial dissection that ignores the anatomy of where the fibers go and just cuts out where the fascia is thickest to define what we now think is a medial collateral ligament, as that's what we're taught. But that ligament doesn't exist. The cruciates exist, they're individual structures. But the medial and collateral ligaments, like the medial collateral ligaments of an elbow, are just thickening of the joint capsule in locations where the joint capsule needs to be able to handle more stress. You can demonstrate muscle fibers inside the fascia lata. You can demonstrate nerve fibers inside the fascia of the arm. And when fascia contracts, it doesn't contract as quickly as go pick up a glass of coffee. Fascia contracts over an hour and a half and uncontracts over another hour and a half. And we don't know what button really turns it on to contract, turns it on to release. But histamine is one of the things that turns it on to contract. And when you walk in and your shoulders are up to your ears, because you've been carrying your briefcase for the last 3 days, the fascia contracted so your muscles didn't have to do the work. And so the fascia is doing the work for you. And now that fascia has to get released or you're going to be up like this for a long, long time. And we don't really know what drug pushes this button to make it undo. So sometimes when the fascia contracts, it's pathology. For example, Dupuytren's contracture, when the fascia contracts in the hand, that's pathological. And it's a contraction of fascia. And how do we release it? Well, as an orthopedic surgeon, I did 2 years of orthopedic surgery residency, so I kind of got to be a conformed orthopedist before I ever got to be an orthopedist. Maybe I was ahead of that time. But instead of doing a Z-plasty incision and removing all this fascia, what we do today is we take a needle percutaneously through the skin and we cut that fascia cord and we release the finger. It doesn't remove the cord, but then you don't have the numbness from the cut, you don't have the 3 weeks of healing and the mess that goes with the surgery, and you've got your finger back because you walk out of my office, it's already open, and your pain is gone by the next day and you don't have anything to heal. Take a look at this video also. This is the spiral line. Remember I mentioned the... Here. I'll give you video, audio this way. Something went, oh, I pulled my cord. Sorry. Oh, thanks. So let me show you that video again. We've got sound through the microphone. Oops. I really want you to see this video. Here we go.
So I'm holding on to the rhomboids that have been resected from the spinous processes here. You can see the white division between rhomboid minor and rhomboid major, and you see the medial border of the scapula here. And if I let go of these rhomboids, you see how they are not really headed for the medial border of the scapula, but really sucked down the serratus anterior. However, if I use them as a strap and put some tension on them, you see how they move that medial border of the scapula, and if we move the camera down to the ribs below the scapula, you see the serratus anterior being moved. Therefore, that Myers guy tends to talk about the rhomboserratus muscle.
So what we're talking about here, this is a visual experience of what I called before the spiral line that goes through the chest. So all of those people, us included, perhaps in this room, that have pain and discomfort, there we go, pain and discomfort from the corner of your scapula, and you think that you've got muscles that attach to that corner of the scapula that are causing the problem, that's not really true at all. The muscles don't attach there. Muscles do not attach to bone anywhere in the body but the inner ear. We'll get to that in a little bit. So just as I started to realize that you could cut the strings that are tight within the finger of a contracture, I started to explore the idea of, well, wait, maybe scoliosis is the same thing. And maybe the fascia tightens and doesn't let the child grow. So scoliosis is a curve with a three-dimensional deformity. It's not an S shape. It only looks like an S shape on the X-ray because it's a two-dimensional X-ray. But the spine is actually growing in a spiral. It's a three-dimensional spiral. 70% of pediatric cases are idiopathic, and there are a variety of treatment possibilities: bracing, chiropractic, myofascial release, surgery. And here's what the curves look like. And we have ways to measure them, we have ways to look at them. But what you see is that there's a trapezoid deformity of the vertebral body, and the rib gets angled and the other rib gets unangled. And where it becomes important to operate on these children is that when you are bent up and deformed as a pretzel, there's not enough room for your lungs to move air and you get pneumonia and you don't do well. And so to stop that problem from happening, we have this surgical procedure to straighten this out and put rods in. And when you look at these children, you can see that there's a hump where the bone is. You can see the angle and you can see the hump. And so myofascial possibilities have been elucidated, showing idiopathic scoliosis not surgically corrected can be helped with myofascial release. And what we started to look at with this was, well, maybe the muscles and tendons don't attach to bone, they attach to each other. and muscles attach to each other through fascia, and the fascia forms this continuity. And what if scoliosis is caused by tightening of the fascia? Then we should be able to feel where the fascia is tight. And if both of those are true, then we should be able to percutaneously cut the tight cords of fascia and release them and let the child grow. And sure enough, that's exactly what we did. We would take these children, show their hump, measure them before and after, and show that they would grow up and spring up even at the time that they were in our clinic from one to the other. And then we had our first child that was 10 years old, and she came in with a hump and with a click. She has nothing left. Not even an x-ray needs to be done. The case before that, there were cords and tight cords in the front of the thoracic spine that you can't get to without opening the chest and cracking the lung. So the procedure of being able to do it through the skin has its limitations, but it can so much change the outcome for so many of these children, especially if caught early. And to me, it pretty well proves that the origin of scoliosis is not idiopathic anymore, because every child is different, every child grows differently, every curve is different, and fascia really explains it, both the pathology and the cure. So here's this person's angle and hump, and then angle and hump is gone. So let's look at another segue. Let's look at fascia in the nervous system and illustrate the association between fascia injury and radiating pain, the connection between fascia and stress, and lastly, the connection between fascia and emotion. So immunohistochemical studies demonstrate Pacinian corpuscles and Ruffini nerve endings in the thoracolumbar fascia. We were taught in medical school they only came in muscle. And then also demonstrated nerve fibers containing calcitonin gene-related peptide, identified nociceptive endings in lumbar fascia, showed that cells were associated with neurogenic inflammation, and theorized that fascia plays a role in chronic lower back pain. If you look at mechanoreceptors that we have all been looking at for many years, we narrow them down to Golgi tendon organs, paciniform endings, and Ruffini endings. And they're placed in myotendinous junctions, joint ligaments, muscles, spinal ligaments. Let's look at the tibial nerve and just see the magnitude of what it is that we're talking about and how the ratios of our perceptions are maybe way different. Just the tibial nerve, there are 3 times more sensory fibers than motor fibers. 20% of the sensory fibers originate in the mechanoreceptors that we just talked about, Golgi, Pacini, and Ruffini endings. 80% of the tibial nerve ends up in small diameter interstitial muscle fascia receptors, and 90% of them are the unmyelinated free nerve endings, some for pain, chemo, and thermoreception, but the majority measure 2 things: shear force, tension, and pressure. That means most of our nervous system is the free nerve endings between the layers of our strings. Okay? Most of our nerve endings. And if you think about injury that causes chronic pain, every person you see injured, their injury is to their strings. The injury is to their fibroblasts and to their fascia. And their fascia has not repaired, and their nervous system is still crying out. Remember I talked about how muscles don't attach to bone, how tendons don't attach to bone. Orthopedic surgery, we were taught tendons attach to bone. The strings of fascia that go through the muscle interweave with the strings of periosteum that cover the bone and take right off again in the strings of the next muscle with no interruption in tissue. And if you want to illustrate that posterior line to yourself, all you need to do is put tension on your hamstring, a little more tension on your hamstring, and then dorsiflex your foot, and you'll feel it. And then drop your chin, and you'll feel it even more in your hamstring. If we had more time, you could all have that pleasure. But you will know right away that you are connected in one piece from top to bottom. And then look how it works. Imagine the strings of fascia going through a muscle, and then imagine the nerves, the unmyelinated nerve endings that go through this fascia, and then imagine that this end is injured, where that tendon attaches, and this muscle contracts and all these cords slip. And these nerves are just these nerve endings are just really notifying the brain of 2 things: shear and slip and movement of those fascia strings and pressure on them. And you get that little bit of slip, and what happens? With pressure or friction, or the pressure and friction that increases with inflammation from food, these nerves light up like a Christmas tree, and your injuries become more open to you. And this fascia doesn't end here. This injury in your butt muscle goes all the way down your leg. And when this fascia tears and this string shifts, and this string shifts and all the way down your foot, it feels like a lightning bolt in a pinched nerve that went all the way down to your foot. And as soon as you go to the doctor and you complain of what you felt, we were taught nerve, burning, we were taught this, the type of symptom that you have should tell us where it comes from. And nothing could be further from the truth. Numbness, tingling, burning, aching, cramping, it doesn't matter what it is. There is no way you can initially differentiate that from muscle, from nerve, from myo, from fascia, from this reaction, because there is no sensation that you can experience that cannot be attributed to muscle and fascia. And that is a travesty that we don't get that yet. Ligaments are arranged in series with muscles. They're not in parallel. We were taught that when you bend your knee, taught in orthopedic surgery, the medial collateral ligament, which doesn't really exist, doesn't come into play till the knee is bent at 90 degrees. And out here, it doesn't really come into play. And what this illustrates is that's not true at all. When my quad muscle tightens, those ligaments are already active. They're part of the fascia of the thigh muscle. My knee has already changed. The whole dynamics of the joint is related to what the muscles around it are doing. And the ligaments function through the full range of motion, not just in one. Nerve endings are not arranged according to a your nervous system is different than your nervous system is different than your nervous system. No two of us are the same. No two of us have our anatomy the same. So when I teach people in these on how to put an study, the anatomy is generalized because your sciatic nerve might come out between two branches of your piriformis, and yours might come out from under it, and yours might come out from over it. And you might not even have a plantar. You might not even have the tendon in one wrist that you might have in the other. We're all very, very different. There's no representation of a deltoid muscle in the movement section of your brain. And the sensors in and near your skin are more active in detecting and regulating movement than the ligament receptors. For example, we were taught in orthopedic surgery that the reason I know my finger is here and now it's bent 60 degrees is because I have a little goniometer nerve inside my finger joint that tells me that's 60 degrees. That's nonsense. The real answer is, as I bend my finger, the fascia here gets tighter and the fascia here gets looser. And my brain can that in such dynamic fashion it can tell me that, which is very complex motion. Related to the fascia slip and how my nervous system can integrate that. So the bottom line is that fascia is more innervated than muscle, and proprioception and kinesthesia are primarily fascia, not muscular. The reason the Ehlers-Danlos syndrome person can't tell they bent their ankle is because they don't get enough response from their fascia to know they bent it that far. And by the time they're over that far and they know they bent it, they're gone. They're already done. So fascia connects pain. Chiropractic, acupuncture, massage, myofascial release, trigger point injection, prolotherapy, prolozone therapy. Fascia is the common denominator in all of that kind of body work. So now let's look at myofascial pain a little differently. We're talking about trigger points in muscle and fascia, and we're talking about how every single trigger point in the body generates two pain patterns, 24 hours a day, whether we are conscious of it or not. It will generate pain that is numbness, tingling, burning, aching, cramping, doesn't really matter. And it will generate a pain pattern where the knot is, and it will send pain in a referral pattern in predictable fashions. So we've seen these charts, we've seen these diagrams, and now let's think about it in terms of what we just saw with fascia anatomy and how does it change that. So as you look at headache, think about migraine and tension and TMJ syndrome, and look at this fascia and realize that the injury is where these green circles are. Where this muscle attaches is where the injury to the fascia is that creates this trigger point. In this piece, the fascia injury is where these green dots are, green circles are, and the pain is in between them. And the radiating pain is where that yellow line goes in response to the fascia anatomy and how the nerves transmit that. The headache comes from this fascia attachment. And all these patterns overlap. And they don't need to be any more specific than that. And one person might call this occipital neuralgia, but it's really not. If there is an occipital neuralgia, it's where that occipital nerve comes out of the fascia, and that's where the injury is. Upper extremity pain in a similar fashion. We might think that we're injured here because that's where we feel it. But the real injury might be here. Might be where the scalene's attached. And the only way you're going to know is not by an MRI. You're not going to know that until you touch the person and find out where they're tender. And of all the things that I've seen, the thing that you can trust and the thing you can believe is where specifically is this person tender. It's either their trigger point or it's their injury. If you can find out where their tenderness is and you can get their body to heal it, that is as close as you can get to a cure for the pain. This could be carpal tunnel syndrome until somebody touches. The cornerstone of pain in the upper body is the infraspinatus muscle. From headaches to arm pain to upper back pain, that's the cornerstone. The triceps muscle will make your shoulder hurt. If you have a patient with shoulder pain and you can't do a thing about their shoulder because whatever the pathology is, but they have a big trigger point in their triceps muscle, if you just teach them how to work with that, you can change their shoulder pain enough to make a difference. If you have wrist pain and your x-ray is normal, and the wrist might even be tender, it doesn't necessarily come from the wrist. It might come from an injury of where that fascia attaches up closer to the elbow. And you can find it and you can see it. If I could have a volunteer who doesn't have elbow pain to come up for a demonstration. Anybody? Sure. Your body's thin enough. Can you take off your sport coat? This is it. Thanks. Just come stand right here. And let me have this on. So watch his talking finger do that. Everybody see the talking finger do that? That's a trigger point in the muscle that lifts that finger. And as I walk down his arm, the ropey band goes away and the twitch goes away. If I push on this where there's no twitch, it doesn't matter. He's totally unimpressed. If I whisper on this where the twitch is greatest, it's an owie. The injury that creates that and the slip is up here in his arm, right there. Feel this tenderness? This is where the injury is, up above his arm. So when he contracts this muscle and pulls on this injury, his fascia slips, ties itself into this knot, and makes this happen. And the pain, if bad enough, would go all the way down to his hand and hurt from his elbow and even maybe his shoulder. Thank you very much. The more you use the muscle and the more it's injured, the more active that trigger point will be. So we call this the talking finger. And with people from New York, that's generally more active than people from more calm places. All right, let's look at lower back pain. So maybe the injury is to the lower back. Maybe. Maybe the injury is to the stomach. The autonomic nervous system is what transmits this pain. This is autonomic nervous system, sympathetically mediated pain. It doesn't know front to back, it doesn't know up to down, and it doesn't know left to right. You have to treat both sides most of the time. This is the front to back picture. Most lower back pain is generated by these injuries. Most pain that goes down the leg is generated by this injury. When you go to the supermarket and you walk outside the supermarket and there's a dent in the side of your car, how do you know? You can see it, right? What if you can't see it? What if it's really, really dark and the dent's really, really small? Don't you think you could feel it? So I just felt the dent in your arm. Unless you know how to feel that dent, you can't tell where anybody's injury is. If you're trying to diagnose pain with an MRI scan and you've never touched the person, you've missed. Let me ask one more analogy. No. I showed you that you don't know about it means it's under your radar. That's okay. But you wouldn't have that twitch, you wouldn't have that ropey band, and you wouldn't have that tenderness where I have the injury. And it's not one injury. It's many times injuries over your lifetime. And every time you injured, your body ran a care program to fix it as best it could. And what you have as a result is over time, your body has done an incomplete job fixing that. That's all. If it bothers you enough, there are ways to get your body to rerun that healing program and get it to fix it. That's how you cure pain. Otherwise, you're just stopping the symptoms of something you can't find the injury for. Well, that's most of pain management. That's why it doesn't work. That's the other question. You go to the emergency room with pain in your left arm, and the best left arm doctors in the world work on your left arm for hours, and you walk out and die of a heart attack. The doctors don't look so good at that, do they? And everybody knows that one. But they miss this one. You go to the doctor complaining about pain in your lower back, and all we ever examine is your left arm. Here's where most of the serious lower back pain comes from. is these injuries. And the pain is in the lower back. And the lower back isn't tender. Pelvic pain, similar thing. Look at pelvic pain, and the injuries in many of these people are either to where their adductors insert, which basically runs the show on pelvic pain and bladder pain, or it's where the pelvic floor muscles insert. The adductors run the bus on pelvic pain and bladder pain and send this pain all the way down the leg. Lower extremity pain starts in the butt. The reason your thigh gives out with lower back pain, it's not your lower back. It's you've injured this tendon right here. And you contract this muscle and pull on it, you get a shot of pain to your knee, and you can't hold your weight. Hamstrings, similar fashion. Shoot this pain right down the leg, and the injuries are where these green circles are. Let's talk about BK amputations for just a second. And let's talk about the whole concept of phantom pain. This muscle sends pain to the foot. When we do a BK amputation in orthopedic surgery, we take that leg, we take a saw, we cut the tibia and fibula, we round them out with a file so they're soft or rounded, kind of like a furniture builder. It's kind of neat. And then you take the muscle from around the back and staple it, tack it to the front, so that when you stick this into a prosthesis, there's skin, fat, and muscle to protect the skin from the end of the bone putting too much pressure. All right, so that's the surgical procedure. Meanwhile, back in Wayne Manor, this muscle is still part of your body, and this muscle still sends pain to your foot, and that muscle doesn't care there's no foot there. That is how you treat phantom limb pain and help make a difference in these people's lives, not giving them bigger drugs, more medicine, and anti-inflammatory drugs that hurt them. And just when you think you got it figured out, remember I said, the autonomic nervous system that transmits this pain does not know front to back, left to right, or up to down, and the muscle in the soleus sends pain to the jaw. And if you're a dentist and you examine somebody's leg, they make movies about you. So if you've got a patient with face pain and you haven't put your fingers on their legs yet, you might have missed that. So how in the big picture does all this fascia injury and all these trigger points create somebody's pain pattern? So here we've got fascia. We've got the strings of fascia through a muscle, and right here we've got the densest part. That's the trigger point. If I put a little bit more pressure, there's enough pressure on all those nerves between all those fascia strings to make it hurt. If I go an inch away and push, I got to push a lot harder before there's enough pressure on those nerves in between the fascia to generate the same pressure that would make the pain. That's why the trigger point's more tender than next door. The injury, however, comes from over here where that fascia attaches, or upline, a whole joint away. You never know. So when somebody comes in complaining of pain, what they relate to you is the total of the fascia nervous system input from their entire body, like their brain a GPS to all these injuries all over. And that's their pain pattern. And then how they feel depends on how loudly this orchestra plays and which solo artist stood up to sing. And then how does that happen? How do you feel today is based on what you've done in the last 3 days that's overstressed your muscles and your fascia, what the weather is going to do tomorrow. And I'll tell you categorically, if you have rain pain and your patients have rain pain, 100% of rain pain is food-based inflammation. And if you want to know just a measure of how much better you would be, that's your baseline. Pain. How well you slept last night's part of this, how much stress you're under, and from my talk earlier today, what you've eaten in the last 4 months is part of your pain. So, fascia plus inflammation equals pain. Food and nutritional supplementation can increase pain, can decrease inflammation. Other do not eat foods are the artificial sweeteners and hydrogenated fat. Now let's talk about fascia shear. Every trigger point you find is in a ropey band of muscle. And every ropey band you examine in any patient is going to have at least one tender end, usually both ends. And what I'm trying to show you is the tender end is the injury that creates the ropey band. And here's how it happens. You have the fascia attachment. The muscle pulls in the direction of the arrow. Some of the fascia slips. It slips a little further. Enough pressure, enough anoxia, enough everything else in that trigger point. And in a bigger way, it looks like this. And then that. And then more. And that's how our injuries form all over our body. This is bladder distension, sexual arousal, tickle, itch. Every sensation you can feel is part of how your nervous system interacts with your fascia. So, how do we show and how does it work? Every patient who comes into my office colors a pain diagram. Blue for pain, red for numbness and tingling, yellow for numbness and tingling, red for pain. And so I've kind of outlined for this person where her injuries are that create this pain pattern, and I'm showing them to you in green. And then in red, I'm showing, good, how all these interact. And these are the areas where her major injuries are causing this pain pattern that you see. You might look at this in all kinds of ways, but the way we looked at it was, let's take these injuries and see if we can get the body to regrow the fascia. Every time the fascia gets injured, it regrows. So if you poke it with a needle and do an acupuncture needle, you're going to create a healing reaction. If you inject dextrose and Novocaine and call it prolotherapy, your healing reaction is going to be a little bigger. If you inject platelet-rich plasma, you've got healing reaction on anabolic steroids. And so we did in one visit her right quadriceps origin, glutes, levator scap, teres, scalene, medial trap. We'll get to what that did in just a minute. Remember I talked about what you can feel and how you can feel these injuries. And what happens when you skin your knee? You bleed. And the bleed makes a scab. And the scab falls off in 4 weeks. And when the scab falls off in 4 weeks, you have new skin underneath. How often does that work? Every time you do it, right? That's platelet-rich plasma. Contains all kinds of growth factors. It's very good for partial tendon tears, rheumatoid arthritis, ligament injuries, muscle injuries. And what's it all about? Let's take a rotator cuff tear. A partial rotator cuff tear means I've injured it lots of times and my body has done an incomplete job putting it back together. And now instead of it looking like this, it either looks like this or like that or maybe like this, but that's my partial rotator cuff tear. The orthopedic surgeon is going to cut that as far back as he can to get reasonably healthy tissue and then staple this to here and send you to physical therapy to get it all stretched out again. Or you can take blood out of your arm, concentrate the same growth factors that made a scab, that grew you new skin, put them in a syringe and poke them into this tendon. And 4 weeks later, when the scab falls out, you have new tendon underneath. How often does that work? Every time you do it. How well does it work? Depends on healing factors and whether a person, cigarette smoke makes it not work, Motrin makes it not work. All the things that stop inflammation, stop your healing. So what happens when we do that to this woman? We inject her in all of these places on one day. All 6 of those spots. And basically taking needles and putting them into fascia insertions where they're tender and where they're injured. And this is what she looks like a month later. Low back pain's lessened, leg hasn't given out. She can reach into cabinets, her neck and shoulder pain is better. So this is initial, this is 1 month, and this is 2 months. She's 270 pounds. She's going to injure those tendons again. She's going to need it done again in a year if she doesn't make some changes to her lifestyle. But that is how you cure pain. As much as pain can be cured, you need to fix the injuries that caused the pain. So what happens when the body repairs the injured attachments? Muscle pull is more solid. Shear force between the layers of fascia is decreased. Strength increases, pain decreases, numbness and tingling go away. I have a patient, workers' compensation, didn't pay for his injections or his treatment. He finally settles his claim. He colors yellow, numbness and tingling down the bottoms of his feet every single day for the last few years. He has enough money from settling his claim for platelet-rich plasma, and his most tender spot was where his glute max attaches on the back of his femur. He comes back to see me 4 weeks later and says, 2 days later, after that procedure, for the first time in 10 years, he could feel his dog lick the bottoms of his feet. Where does the numbness and tingling come from? I don't know. But I do know that we don't have the answer because it's much more than just what's going on in the spine. How many people do you see with chronic neck pain? Chronic neck pain and chronic headaches after a motor vehicle accident. And if you do a flexion extension cervical spine, you'll find that they slip. There's a tiny slip with anterior and posterior motion. And what happens when the cervical spine slips when you look up and down? The muscles go into spasm and you grow spurs on the joint to minimize the slip. If you take platelet-rich plasma and inject and get these ligaments to strengthen, a year later it's gone. The slip's gone, the pain's gone, cervical instability is much improved, and people get a whole lot better. Let's talk about fascia and stress, the emotional component to what fascia does in the body. This is a study done in the mid-80s, putting EMG electrodes into normal muscle and an EMG electrode a quarter of an inch away into trigger point, showing that electrode in trigger point has spontaneous electrical activity, and electrode in normal muscle a quarter inch away is flat line. And so I'm going to show you excerpts from the video of this particular study. And so here is the researcher and the subject and the electrode in the trigger point with spontaneous electrical activity and the electrode in the muscle without, and then progressive stress. And when you stress these people out, the trigger point in the trigger point gets bigger, and even more progressive stress. And the way this progressive stress was done was asking this person to count backwards by 7 from 900, and then making her feel stupid when she got the first one wrong. And when you stress people out, this is what happens to their trigger point system all over their body. So is it any wonder that stressed out people hurt more? And as we get stressed, the sympathetic nervous system effects increase, trigger point activity increases, and the orchestra of pain generators all over the body increases, causing muscle tension, headache, back pain, but it's all the same origin. So we were designed to run away from tigers. But how many tigers were we really designed to run away from? And I suggest we see many more than we were designed for. We were designed to run away from one. We weren't designed to run away from one every time a horn beeps, phone rings, friend scowls, or loud sounds or frights. We were designed to run away from one, and we were designed to know that all we really had to do was run faster than George. Responding to the tiger and this whole stress response exploits the communication link between fascia and the autonomic nervous system. Let's talk about fascia and communication. It is hypothesized that connective tissue proteins convey information and tissue memory. And body workers speak of tissue memory. I'll suggest, rather categorically, there is no such thing as muscle memory. Muscles don't remember anything. Otherwise, after a stroke, you'd still know how to walk. So when you want to change your golf swing from one plane to another, the only way you know where you are in space is how your fascia strings are connected. So if you want to change your golf swing, you have to erase that fascia line and create another fascia line so that when you hit that, your body knows exactly where it is. That's fascia memory. And when you have a needle in somebody's fascia, sometimes they'll relive their accident and relive their trauma. Hands-on body workers see the same thing. The connective tissue signaling network was postulated by Helene Langevin as early as 2005. And the term was made fasciology and fascia anatomy. And there's a 3D structure, a Chinese human project, showing, based on digital data sets and virtual 3D, line-like structures similar to acupoints and meridians and collaterals. And basically they showed that acupuncture points are fascia points. Fascia is acupuncture. And when you put your needle into any point, you are touching fascia, and that's how the change is created. Fascia is under the regulation of the nervous and immune systems. It regulates the function and living status of cells and provides a stable environment for cellular function and survival. It does not talk about the 9 systems. It refers to all cells, tissues, and organs wrapped and segmented by a supporting, storing system. The fascia anatomy is different from regional anatomy because it also acknowledges change with time, morphology, function, and time. Anatomy should be studied as dynamic, not as a static piece. Cells and organs are maintained through interaction between supporting, storing, and functional systems. And the fibroblasts form a body-wide cellular network. Acupuncture is widely used for anxiety and depression. It has a neurotransmitter effect. Catecholamine-storing cells and noradrenaline are at acupuncture points in the fascia. That's how they get released. The healthy adult limbic system shows acupuncture affects the limbic system, and that's shown by functional MRI studies. Interoception is a fascinating field. Primates, that nerve in the autonomic system that goes from the fascia injury to my brain goes to my insular cortex before it goes to my pain center. I know how I feel about that pain before I know that pain exists. Sensitivity and processing of stimuli is done in the insular cortex. Pain, temperature, itch, tickle, sensual touch, muscle and visceral sensations, sexual arousal, bladder and intestinal distension, hunger, thirst, air hunger, emotional awareness is all in the insular cortex, and that gets the primary input from the muscles and the fascia by these unmyelinated free sensory nerve endings that project to the insular cortex and not the somatosensory cortex. The extent of this connection is that adolescents with substance use disorders show receptive processing. Patients with major depressive disorders show disrupted perception of bodily responses that reduces their experience of positive arousal. All fascia-based. It's also related to IBS, and fibromyalgia patients have been shown to have increased pain stimulus. A minority of sensory nerves are myelinated mechanical receptors for proprioception, Golgi, Pacini, and Ruffini endings. 80% terminate in free nerve endings located in fascia structures. 90% are slow-conducting C fibers relating pain. Functional MRI activation of the insular cortex. It doesn't show activation of the somatosensory cortex. Interoceptive nerve endings coming from our periphery outnumber proprioceptive nerve endings more than 7-1. And the interoceptive nerve endings measure mechanical tension, pressure, and shear deformation. 40% are responsive to light touch and myofascial manipulation. And myofascial and visceral therapists encounter psycho-emotional release and response during therapy on a regular basis, and this may help. The complementary medical practices promoting inner mindfulness, refining internal listening skills, yoga, tai chi, qigong, Feldenkrais, Pilates, body-mind centering, all are effective for diverse clinical conditions, and they all tie into their effect on fascia. Specialization fragments us. We need to connect our silos. We need to bring ourselves together, and our commonality in how each of our specialties and each of our stuff affects fascia, that commonality brings us together in treatment whether we want it to or not. Whether we know it does or not, it actually does. It doesn't matter what discipline has selected us, we influence by intention the body's ability to heal. Fascia forms a true continuity through the entire body, influencing all systems and being influenced by many modalities of therapy. This is a 3D schematic. Fascia of the human thigh. Breathe, relax, and I hope you enjoy this as much as I enjoyed making it. Thank you. I think we have time for questions.
We got time here. Ooh, let me lower this. Let me just lower this down just a bit here. Wonderful.
Right. Thanks for so much inspiring lecture. It's new to some of us. But I just wanted to ask, by form of inquiry, in recent times, introducing massagers, electronic massager, TENS, transcutaneous electronic nerve stimulation for shoulder pain, in all those areas that you have mentioned. From your own experience, how effective are these electronic massager? They are small portable tool like this with TENS. How effective are they in alleviating this fascial problem?
The quickest way for anyone to reduce their pain is to find this tight knotted muscle and step on it as hard as they can and squish it. As fast as you squish that knot, all of the strings that go through it are released or less tightened. And what comes from it is less. And that will last until the knot tightens back up again. And it's such a simple procedure, you can learn how to do it. I wrote a book about it. I brought a few of them with me. Comes with a little rubber ball, so people can push all parts of their knots. And you're allowed to push as hard as you want, as long as you can the stuff that you pass. And the electric massage will do that just fine. TENS unit, the other part of the question, they kind of miles. They work when they're on. If they work, they work when they're on. That's a fine thing. It doesn't hurt anybody. It's okay to have some electric magic quiet down the rush to your brain. But it's like when you pick up the telephone from our grandma on Christmas, and the operator gets on the phone and says, sorry, all lines are busy. Please try your call again later. That's what a TENS unit does. Just ties up the lines. Yes.
All right, Hal, after spending some time with you last night, I take it you're a black and white guy, yes or no? Okay, that's fine. All right, so I certainly agree with you on a lot of the muscular stuff. I do a lot of shockwave therapy with PRP as well. A couple of questions. With regard to absolute tears within the distal tendons, as we see with jumper's knee, we see them with patella tendons, we see it with epicondylitis and the like. Your preference for PRP, with ultrasound guidance or without, number one. Number two, as we look at some of the fascial bands that extend above and below the areas where the actual tears are on ultrasound, are you attributing the tears there to the fact that that's the weakest link, basically where the fascia extends to? Yeah.
So every piece of that tendon that's tender is part of an injury, whether it's the biggest injury or just the micro injuries through time and playing on the swing set for years ago, you never really know. But every part of that continuity in fascia may need to be repaired to make the problem go away, not just the biggest. If the tear is stable enough, you can use PRP. There's an article to show a 75% Achilles tear will repair with PRP. 100% tear, probably not. So, I don't know, does that answer the first part of the question?
It answers the fact that, certainly there's a tear that ultrasound. I guess the second part of that is we tend to go after the tears themselves when we have either shockwave or PRP or both together. Some of these tears are clearly below where you're feeling there to be a trigger point. So there's trigger points above and beyond the tears, more cephalite.
The fascia injury is beyond the trigger point.
So are you taking into effect the PRP injection both within the tear and more proximal in many cases as well?
Yes.
Okay.
And it doesn't matter whether you do it under ultrasound guidance or not. What matters is that you get the needle in the right place with enough pokes to create enough injury and put the PRP in. So, for me personally, if I'm doing a shoulder, I will look at the tendon to make sure that the tender parts are the places where the biggest injuries are, to make sure I'm not missing anything. But that transducer is in the way of my needle, and my hands can feel more than the transducer can see. Once I know that my hands collaborate with what the transducer sees, I put the transducer away and take out my needle from my hands. That's just my technique and the one I teach.
Okay, Hal, thank you very much. It's an amazing lecture. I mean, you put us just beyond. Quick question. Let's go to the human body again. You put a lot of structures together. When you put the human body, we have a skeleton, we have the muscle tissue, we have the nervous system, which is the motor and the sensory, and we have the fascia, or the fascia, whatever you want to call it. When we have a radicular pain, and we have a shooting pain that go in a radicular way, And we have a patient who has a scoliosis, and that scoliosis made him unstable. So he got a radicular pain, shooting pain, neuropathy, sensory. There's fascia pain with it. You referred everything to the fascia, and the sensory and the motor and the changes. It's the fascia-related changes, which is encoded in the limbic system, encoded centrally in the brain and all of this. But there is also a motor part. There is also a radicular part. There is also a nerve root part that has taken place. There has been a scoliosis in this patient with instability that's been all the way encoded in the brain. Can you go ahead and say this is fascia related or it's a brain related?
Or
brain related. Encoded.
More fascia related than brain related. Because the structure and function. I started out with the same education you did. I did 2 years of orthopedic surgery and totally believed the spine model and everything you said. But as I have changed in the last 25 years, most of that pales in what I can touch and what I can feel and what I can find. I wouldn't look at the scoliosis as the instability. I wouldn't look at, because it's not an instability, it's the fascia is too tight to release. Part of that that's unstable, it's held like a rock. The pain that's going down the leg that we think is radicular, I seriously question that. I had a patient come to me with pain going down his leg, and I examined him. So he's got a decreased reflex, he's got decreased quadricep strength. His MRI says herniated disc, free fragment, migrated inferiorly and pushing on nerve. I said, I don't think I can help you. Go have the surgery that's scheduled for next week. He said, I'm a bodybuilder, I'm not doing the surgery. I hear you do good with your needles, just stick them in me. I injected his lower back and his butt muscles. 3 weeks later, he's pain-free. 10 years later, he's back in my office, same pain. I do the same injections, pain goes away again. I said, you know, I've been wondering for 10 years. Can we get another? Trigger points. Just trigger, quadratus lumborum and gluteals. Really simple stuff. So nothing in his disc, nothing even near his disc, no ozone near the disc. I didn't know about that then. So this is 10 years later, and I looked at him, same pain, same injections, goes away again. I said, can we do another MRI, please? Because I've been wondering for 10 years what happened to that disc. He's got 4 herniated discs now, not just 1. So sometimes that disc is the offending agent and you need to take it out. But so infrequently, and we don't know until we learn how to touch. And that's the point. Everything we learned is true, sometimes. And then there's this whole other world that we were never introduced to that causes us to miss the boat and makes us look at chronic pain and go, we can't fix that. All we can do is make it numb. And I'm suggesting all you need to do is find the injuries and get the body to heal them, and then the pain goes away.
How do you explain when the surgeon intervenes and fixes it, the pain goes away?
Yeah, sometimes that happens, and sometimes that's the right answer. Yeah. And that's what's so confusing. But to do that first, before somebody with this skill set does this, is a travesty. And to go with radio frequency and kill nerves because you think that that's the pathology before you recognize the fascia injury is also. That's the point. Not that what we learned was wrong. It's that this new information changes the perspective on what we always accepted as true, that we should have a question about and not just be doing. I remember reviewing a case for the Ohio State Medical Board. They this lady's license for doing epidural steroid injections more than 3 at a time and waiting 6 months. And now they're done like they're water. And way overdone, in my opinion. The pathology. Any other questions? Our time is done. Exactly. But everybody's examining the left arm.
Well, many of them do work.
Yes.
And I do take offense to some of the statements that you made earlier about epidural steroids, because there's excellent literature in a lot of pain journals that show the efficacy.
Oh, no, I'm going. There's also just as viable literature with exactly the opposite viewpoint. So sometimes they work, sometimes they don't. I would like to introduce Louis Kamkumar from Springfield, Illinois, talking about TRPV1, a very important target for analgesics.
Thank you very much for inviting me for this talk here. And Bachman's lecture, I got to fill in a very large shoes, so I'm not going to do it or not. So basically, we've been talking about pain. There are several targets for pain, but I'm going to talk about a target called TRPV1. I'll tell you what TRPV1 is. Basically, what are TRP channels? They are transient receptor potential channels, were first described by Drosophila, where photoreceptor carrying a TRP gene mutation exhibited a transient voltage response. In fact, whenever people worked on these flies, they gave them odd names like shaker channels or ether go-go, the way they behaved. But similarly, they also named a type of channel with this name because it produced a transient voltage response, but I feel it's a misnomer. That's the reason this channel is not being very much appreciated. But in fact, this is a very, very important channel for carrying pain from the periphery. So TRP channels respond to temperature, touch, pain, osmolarity, pheromones, and taste and other stimuli. There are 28 different types of TRP channels have been cloned and characterized. And the role of TRP channels are not only with the pain, they are much more than other areas of the pain. Areas are also involved. And recently we have shown that TRP channel, TRPA1, is involved in insulin release and so on and so forth. And moreover, the other area of my study, what I'm looking at is also that these TRP channels are target for several phytochemicals. There are lots of food ingredients we eat. One of the channels which I'm going to talk about is TRPV1, which is the target for capsaicin. And the TRPA1 is the target for ingredients in garlic, in horseradish, in fact, allyl isothiocyanate. And that's how these sensory receptors are activated, and they've got benefits, which has been already talked about. So as I told you, this is because the name is being a problem to appreciate this receptor. Basically, there are several types of TRP channels. I told you there are about 28 TRP channels, but mostly I'm going to talk about TRPV1, given the time constraints we have. And these TRP channels are also interestingly, they act as a molecular thermometers as well. In fact, TRPV1 is the one which I'm very much studying, which is what I'm going to explain to you. How does this work? Okay, so TRPV1 I'm going to talk about, as I told you, TRPV1 is activated by an ingredient, hot chili pepper, called capsaicin. And this is what, whenever chili pepper touches your skin, you feel this burning sensation. And it has been shown that this receptor is upregulated in chronic pain conditions. That's what we are interested in. That's what we are studying. I'm going to talk about that. In fact, one of the compounds which I'm going to talk about, and Dr. Idalora is here, who has done a lot of work on that, resinoferatoxin. It's the second part of my talk. I go to rush here. So TRPA1, as I told you, it senses temperature, and TRPM8, it senses the soothing sensation. Whenever you put mint in your mouth, you feel the soothing sensation. So this channel gets activated temperatures around 15 to 25. And in fact, TRPV1, which gets precisely activated at 42 degrees centigrade. And this is what carries thermal sensitivity. And we also believe this channel is important for inflammatory thermal hypersensitivity. I'll show you some studies why we believe that. And also, as I told you, these are all activated by several ingredients. Hot chili pepper capsaicin activates TRPV1. And also TRPA1 is activated by garlic as a substance called allicin, and horseradish, which has got an allyl isothiocyanate, like mustard, and also cinnamon, cinnamaldehyde. All these activate these receptors. That's a whole talk altogether. We have got lots of these phytochemicals. We believe they activate TRPA1, which are expressed in pancreatic beta cells, also in enteroendocrine cells. There is always anecdotal evidence that these ingredients do health benefits, but there's nothing has been proven. So we are in a stage of trying to show how exactly it's being brought about and the mechanism of action. So this is the basic thing. Everybody is very familiar with this. You have peripheral pain, And then, of course, this is the dorsal root ganglion neuron, and then they make synapses here, and then information goes to the brain, and then things can happen at the periphery, and also happen at the central nervous system, and also beyond the brain, which is you call a central sensitization. So when you talk about a pain, 4 impulses normally go into the brain, but whereas when it's sensitized in chronic pain condition, you have several impulses go into the brain. That's why you feel the pain. So the physiological and pathological functions of TRPV1 is involved in temperature regulation. I told you, senses noxious thermal stimulus. It releases CGRP, a potent vasodilator, which we talked about a little bit. And ischemia results in low pH, and the tissue damage produces bradykinin. Both can activate, because this channel can also be activated by hot chili pepper. In fact, temperature, capsaicin, and vinegar activates this receptor acidic pH. When you eat hot chili, inadvertently you take a very hot chili spiced with capsaicin, hot temperature, and garnished with vinegar, you feel the pain. Okay, all these activate this receptor. And also it's involved in micturition reflex and so on and so forth. So the main clinical uses of vanilloids, I mean the pain relief, it produces desensitizing or tachyphylaxis. That's the mechanism. They believe that TRPV1 locally applied as a capsaicin cream can produce its effects, and also it can increase the microcirculation by releasing CGRP. And of course the counter irritation mechanism, and in bladder hypersensitivity it plays a role, and in several other situations this TRPV1 is involved. So in the DRG neurons you can see only a certain number of neurons, only 30% of the neurons are labeled when you use this, and always whenever you do labeling to make sure it is specific, we always do a knockout animal where this tissue has been knocked out and you do not see any labeling. This is the paw skin. And whenever this peripheral sensitization, what does it mean? So these receptors are getting sensitized by inflammatory mediators. So inflammatory mediators activate several pathways, and one of the pathways we have extensively studied is protein kinase C. When you activate a protein kinase C, you can see a pH response of this TRPV1 potentiated massively, almost 20-fold. In fact, here again you use capsaicin, 300 nanomolar, and this is massively potentiated. This is what peripheral sensitization is all about. The receptor is now responding very, very rigorously to a normal stimulus. And we can also use another compound which activates the receptor called N-arachidonyl dopamine, also potentiated. And in diabetic peripheral neuropathy, what we have shown is that this is the capsaicin response. You take a DRG, you record currents, and then in hyperalgesia, you see a larger response of TRPV1, and then hypoalgesia, where there is a smaller response, and we can also show that TRPV1 is increased expression. All these is pointing out to is that this receptor is upregulated in diabetic peripheral neuropathy, and we have studied various other painful conditions as well. I do not have time to talk about that. In all these conditions, we see an upregulation. So this is diabetic peripheral neuropathy. Again, you can see increased expression. And also in the peripheral terminals, also in hyperalgesic, there is increase. In hypoalgesic, there is a decrease. And interestingly, later on, what we have found, studied this in DRG neurons, what we found is that not only these receptors are expressed in the periphery, but they're also expressed in the central terminals. And nobody knows what it does in the central terminals. Okay? So how can we study this? See, this is the DRG neuron, and this is the synapse, and this is where these receptors are also expressed. And interestingly note that these receptors are not expressed in the second order neurons. They are specific to this 30% of the neurons I showed you where TRPV1 is expressed. And you can see this is the spinal cord cross section. We are trying to label for TRPV1, and we see only in the dorsal horn. It's not seen in the second order neurons. So that's an important point. That means when you try to use this drug, you can be selectively affecting the peripheral nerves rather than affecting in general everything else. And this is again trigeminal nucleus. You have 3 branches. This is oralis and interpolaris, and this caudalis. This is what carries the pain sensitivity. And what we show here is that only in this caudalis you can see its expression, not in other areas. All these we are trying to show the specificity of this receptor expression. Okay, so how do you study the synaptic transmission in the brain? So we can have a brain slice and then try to stimulate the peripheral terminals, or you apply capsaicin, you can see increased activity here. See, whenever you record from a slice, you can always see spontaneous transmitter release. That's what you see. Time a glutamate it gets released, vesicle gets released, you get small blips like that. When you apply capsaicin, you increase the number of those blips, indicating that they are causing release at the center. This could be a part of the central sensitization as well. Okay, and we can also do evoked currents. See, when you evoke a current, that means you stimulate the terminal, the dorsal root, then you can get a synaptic response, and this synaptic response can be inhibited immediately within few minutes after application of that, but not the spontaneous activity. So the idea what we are trying to promote here is that activation of this receptor can cause a depolarization block and prevent neuronal transmission, okay, in the short term. And again, as I showed you, the PDBU, the activation of protein kinase C, all these inflammatory mediators which involved in glia activation and so on and so forth, they all produce inflammatory mediators. They activate second messenger pathways, and in fact they can activate protein kinase C or protein kinase A. Then you have increased activity, and this is part of central sensitization at the spinal cord. You can have central sensitization beyond the spinal cord as well. Okay, this is again hyper and hypoalgesic animals. I can see increased expression in the dorsal horn. And recently what we have been doing is that in diabetic peripheral neuropathy, I told you these receptors overexpressed, and here we can show that in STC treated diabetes which feels hyperalgesia, you can see increased activity here. Can you see this is the normal control response here and increased activity. So this might be playing a part of the role in inducing pain perception. But when you use a knockout animals, we can knock out the TRPV1, and this animal does not feel any pain, which is specific to this. So in summary, part 1 is TRPV1 is expressed in both peripheral and central terminals. Capsaicin-induced TRPV1 response is potentiated, causes central sensitization, and also in hyperalgesic diabetic animals, you TRPV1 expression, and synaptic transmission is enhanced in diabetes. Okay, so this is a very good target, as you can see. So people are trying to develop drugs. So several companies have developed drugs, and in fact Amgen has developed a drug which almost in the clinical trials, and capsaicin, GRC 6211, we have did a lot of work on this drug. In fact, this company sold this one molecule to Eli Lilly for $300 million, in fact. But you know the problems with TRPV1 antagonists? It would be a very, very good analgesic, but the problem is it produces hyperthermia. In fact, when Amgen did their clinical trials, they treated the patient. One of the models they use is tooth extraction pain. So when you extracted the tooth, they gave this drug. It was perfect. Everybody's celebrating, and champagne bottles are open and everything. But they found out by that evening, the body temperature, he developed a fever. Okay, so body temperature is increased. So when the body temperature is increased, it's very difficult to go through it. So Amgen has completely dropped this idea. Okay, so we do basic science, so we do not want to drop this idea. The idea is that there is another compound which comes from a cactus called resinoferrotoxin. So the resinoferrotoxin is super potent. It's an ultra potent compound, and what we have shown is that it is almost 1,000 times more potent than capsaicin. And the question is whether we could use it. Dr. Ida Laura, who is here, he has done a lot of work. We have done work independently, but somehow because of the commonality we have come together, and he has done some of the pioneering work in that, and he's going to talk about that. And it's a very, very potent compound. That's all I can tell you. So what we are trying to do is that use this compound and see what we can do with it. So capsaicin, you can see a response, and then the response gets washed out. This is an electrophysiological study. Whereas when you do RTX, the response does not get reversed easily. So it's a very, very potent compound. That's the basic idea. When we do a lot of single channel recordings, this is a single channel TRPV1 recording. You can see, you can measure the potency by the open probability, how often the channel opens. And here you can see the open probability almost 0.96. whereas capsaicin you can have a probability of 0.545. With RTX, you do not have a dose response curve because you use the lowest concentration, you wait long enough, you will get almost a P open of 1. Okay? This is the most important slide to remember, is that if you apply capsaicin, you get a response and the response comes down, whereas in the case of RTX, you can use a very, very low concentration. What you're using, 10 picomolar. When you use the 10 picomolar, you depolarize the membrane and prevent nociceptive transmission. Okay, that's what we show here. So we believe that in the short term, it produces depolarization block. All right. So when you produce depolarization block, it does not induce pain. Whereas capsaicin ointment you apply, there are several capsaicin ointments are available in the market for treating diabetic peripheral neuropathy. So you do not have, I mean, you have lots of pain for few days till the receptor gets desensitized. Whereas with RTX, we believe that you will not have the initial pain. But interestingly also, this is again synaptic transmission. RTX is long lasting, capsaicin is washed out. And similarly, when you do stimulate the dorsal root, you can induce depolarization block, then prevent nociceptive transmission. And in several pain models, we can see this is an inflammatory pain. You can prevent the pain sensation. But it doesn't have anything to do with mechanical pain sensitivity. It does not touch the mechanical pain sensitivity, which is quite interesting. So what we see here is that mechanical pain sensitivity is absolutely unaffected. And I'm not going to go through this. I mean, this is if you inject capsaicin onto the paw, you see lots of pain, in general pain. So the animal exhibits behavior called nociceptive behavior. Whereas in after RTX treatment, here we RTX intrathecally. Okay, when you treat with RTX, you do not see any pain at all in this animal. They do not feel the pain. But interestingly, when we take these animals, then we look at the TRPV1 expression. What you can see here is that this is TRPV1 in the control situation, what I showed you before in the dorsal horn, whereas RTX after treatment, you do not see any of these terminals. So what we believe is that because of increased calcium flux, all these terminals are ablated, but I do not have any evidence for that, or the TRPV1 channel itself has been removed from the membrane, or the terminals are ablated. So, so that is how it brings up the pain sensation. But interestingly, even though you inject intrathecally, the terminals are gone, right? But you do not have any issues with the DRG neurons. All the DRG neurons are intact. Even if you look at the peripheral terminals where the innervation occurs, and you have the peripheral terminals where TRPV1 is intact as well. So the idea here is that we want to specifically use this to cause terminal pain, block the pain. In fact, this idea, Dr. Idalora, who has started, in fact, is in clinical trials. They're using people with chronic pain conditions. You keep on giving morphine, it's increased. Eventually, people probably die of respiratory arrest rather than anything else. Whereas you give RTX, you eliminate the pain transmission, so be pain-free without feeling groggy. But interestingly, what we found is that this is an interesting slide as well. Peripheral terminals, after 10 days, you don't see any TRPV1, but after 2 months, after 60 days, these start regenerating. Okay, we can also behaviorally, we can see when you test the responses, you can get the responses back. But interestingly, we have even after 5 months, we do not see any regeneration of the central terminals, which we found to be very interesting, but it can have both positive and negative effects because nobody wants to lose terminals forever. Do you know what I mean? But we have kept it for 5 months. We have tried some other animals about 6 to 7 months as well, similar responses, but the DRGs are intact. So the basic idea is RTX is a potent, irreversible and slow activator of TRPV1. It can prevent action potential generation by inducing a depolarization block at very low concentration. You can use picomolar concentration. Hence, very low concentration of RTX can be used over a long period to induce sustained activation of TRPV1 without inducing pain. Also, induce nerve terminal ablation. In the long term, it causes nerve terminal ablation. In the short term, it causes depolarization block and prevents nociceptive transmission. In the long term, it can ablate terminals. Okay, so these are all the therapeutic implications, basically whatever I've been telling you about. So these are the funding agencies support this work, and some of the people who've done work in the lab. Most of the work done by Dr. Yu and Dr. Beshnoy and Parul and Joe Jeffrey. Thank you very much.
Okay, can do now.
You turn that one? Okay, go ahead.
Okay. Hi. My name is Romulo. I'm from Fiocruz, Brazil, Rio de Janeiro.
And it was actually RTX. They came to my lab, they videoed me, and then they were in a television actually a while ago, 2-3 years ago.
And I work with ion channels, and in the context of pain, cancer, or parasitic disease. And we also studied the TRPV1 receptor. And you show results very, very, very well done. And I would like to know one simple question. You used RTX in treatment of humans, right?
Dr. Idalora, yeah.
Yeah, and you did not see any adverse effect?
I'll talk about it.
Oh, you will talk about it tomorrow.
No, today is going to
Today?
After me, yeah.
Right now? Okay, then I will keep this question for you.
Yeah,
Thanks.
the animal experiments, what we have found is that we can give even intraperitoneally 200 microgram per kilogram RTX. The animal is perfectly fine, but the animal can walk on fire because the temperature sensitivity is gone. Other than that,
We don't see much.
yeah. Okay.
So, in your talk, you mentioned the triple V1 agonist and antagonist both can be as a target for the painkiller.
Yeah.
So, of course, they use a different mechanism. So, I'm wondering, so what type of pain the agonist can be used to treat?
I mean, the agonist basically, see, antagonist blocks the receptor, right? Agonist, over a long time, desensitizes the receptor, or in the case of RTX, it ablates the terminal. Because this channel is open for a long time, lots of calcium fluxes in, and the terminal is gone. That's what we believe in, but we don't have any evidence for that, okay? So, both the treatment eventually prevents nociceptive transmission, right? So agonist and antagonist both work a similar way. So we have tried it in diabetic peripheral neuropathy. I mean, we are in fact right now trying to use a cream form, RTX, trying to cause the same effect. With the RTX is the very low concentration, you can induce the depolarization block. That's the point we are trying to emphasize. Do you follow that? When you follow depolarization block, you can prevent, whereas capsaicin when you apply, apparently these patients have really burning sensation for about 2 weeks. After 2 weeks, either the terminals get desensitized or it's probably ablated, right? Then the pain is gone for quite a while. So when we use RTX cream, we believe that because of the depolarization block, you can prevent immediate nociceptive transmission. But you got to use the right concentration. If you use higher concentration, then again, you're going to activate the channel. We got to use the concentration which produces desensitization block. Yeah.
As far as mechanical pain, certainly temperature-induced pain is gone. So any type of noxious mechanical pain is still transmitted or is not transmitted?
It's transmitted. So, I mean, even allodynia, that's the most of the thing we are trying. The allodynia is still in fact. But in fact, process what we are trying to look at, the TRPV1 activation peripherally causes central sensitization, and that central sensitization is responsible for allodynia. All right, what we are trying to trying to do some experiments to show that if you block the peripheral input, you may not form the central sensitization, and therefore you may not develop allodynia. Yeah.
Mechanical pain, would that be blocked?
Okay,
screen's not-
and we're just not going to record, you're not going to record this one?
Oh, no recording, okay.
I'm incognito.
Our screen is blank too. It's really incognito.
I'll wait.